just going to go ahead and get started right away with cardiac ischemia. Let's say we have a 50-year-old gentleman that's presenting with crushing chest pain radiating to the left arm, also no shortness of breath, sweating, and nausea. EKG shows ST segment elevation of V1 through V4. So what's your kind of preliminary diagnosis and any lab testing you would obtain? So I heard STEMI, so ST elevation, myocardial infarction, and we're starting first labs we'd get is troponin. What else would you want to? What other labs would you want to obtain?
Like basic lab, like CBC.
Yeah, base labs, CBC, electrolytes, magnesium, BUN, creatinine. Good. And then what is special about the troponin? So first of all, what kind of troponin do you want to get? What are like the two little letters in front of the troponin when you order it? So what I'm thinking is HS, so high sensitivity troponin. That's the new generation of troponin. So the old generation of troponin wasn't the high sensitivity. So this troponin is more sensitive to myocardial injury. What other important diagnostic tests would you obtain at this time in a patient with chest pain in the emergency room? EKG, yeah, exactly. So, and then with this distribution, that'd be more of an anterior MI. So what vessel would you think of being involved with the anterior MI with leads V1 through V4?
LAD.
Yep, LAD. So labs you would get, base labs, serotroponin. They do like to test this on exam, which is if you are concerned about a reinfarction or another episode of myocardial infarction after an initial heart attack within 48 hours or 72 hours, then you'll obtain a CKMB level. And then within the first 6 hours, you'll want to obtain an EKG. That's actually more sensitive than troponins within the first 6 hours. So initial medications, does anyone know the acronym for initial medications for ACS, acute coronary syndrome? Yeah, Monobash. So this is a little bit out of date with current practice, but it's a good acronym to remember and it's relatively accurate for the board exam. So Monobash stands for morphine, oxygen, nitrates, aspirin, beta blocker, and statin, and then heparin. I don't know what the second A is. Do you know, Tate?
ACE inhibitor.
ACE inhibitor. Okay. And I've listed those out. The main ones that you want to think about are dual antiplatelet therapy. So that's usually something like clopidogrel, Plavix with what other commonly used antiplatelet agent? Aspirin. Yep. And does anyone know the loading dose of aspirin? 325 milligrams. So common loading dose of Plavix is 600. So for the test, you usually want to start with dual antiplatelet therapy, usually with Plavix and aspirin, and then starting a heparin drip. And is heparin an antiplatelet or anticoagulation medication? Yeah, anticoagulation agent. Great. And then often these patients respond well to sublingual nitrogen if there's chest pain, but sometimes require a nitroglycerin drip. If a patient has flash pulmonary edema, and that's very evident on chest x-ray, you can consider diuresis with something like IV Lasix. A contraindication to that is hypotension. Monitoring, you'll want to get routine vitals and telemetry, but what's the best intervention we have for heart attack? Cath with, so cardiac catheterization, and then what do we do in the cath lab? Exactly. Yep. PCI or percutaneous intervention with stenting. So the goal is by the time the patient enters the door to balloon, which is the PCI with stent within 90 minutes, or thrombolytic within the first 6 hours if PCI with stent is unavailable. What are indications for a CABG or a coronary artery bypass graft? Yep, three vessel disease, or what other indication? left main disease. And the pathophys of an MI, yeah. So pathophys of a myocardial infarction. So what percent occlusion of the thrombus is kind of what I'm getting at here. Basically, plaque rupture, typically atheroembolic plaque rupture with complete or 100% blockage of blood flow in the vessel. Okay. What's the long-term treatment after somebody has a heart attack in the hospital?
People want the dash.
Yep, good. So cardiac rehab, ACE inhibitor, statin, dually antiplatelet, usually with 12 months if they have a drug-eluting stent placed, and then aspirin indefinitely. And then risk factors for heart attack:
Smoking.
age, smoking. What other medical risk factors?
Cholesterol.
Yep, lipids,
Metabolic.
diabetes, yep, metabolic syndrome, ESRD, and HIV are also tested, and then family history as well. With vessel involvement, so with V1 through V4, we already talked about it. That's an anterior MI with LAD, 2, 3, and AVF. What region of the heart would be affected? Inferior, good. And what artery is that? Would be in that territory. Yep, RCA. What drug do you want to avoid in an inferior MI?
Nitrate.
Nitrates, good. One in AVL, if you see ST segment elevations in those leads.
So, I'm sorry, what?
Yep, lateral. And what vessel is that? Yep, circumflex. And then V1 and V2. Yep, septal. All right. So this is very high yield for the board examinations, and that's complications in the acute and subacute time frame after an MI. So what's the most common cause of death a couple of days after an MI?
Stroke.
Not stroke. Reinfarction is a good thought. Cardiac arrest due to what?
You know what, guys?
So why do we keep patients on telemetry?
Lower.
Right, arrhythmia. So most commonly, yep, VFib or VTAC. Let's say a patient, 60-year-old gentleman, presents with acute dyspnea, chest pain 3 days after revascularization. And then you hear a new whole systolic murmur, best auscultated over the apex, hypotension, tachycardia, dyspnea, on room air. What is your likely diagnosis in this patient?
Interseptal tear.
So interseptal tear is a good thought, but the time frame here and then the location of the murmur makes that less likely.
Oh, papillary.
Yep.
Blood rupture in the chest.
Yeah, good. So papillary muscle rupture leading to mitral regurgitation. And high yield for board exams. Why is the papillary muscle rupture? What part of the muscle is most likely to be affected and why? What part of the muscle? The papillary muscle. So basically there's posterior medial papillary muscle rupture most commonly in the papillary muscle rupture leading to mitral regurgitation following MI. And that's because when there's infarction that affects the posterior descending artery, that's the single blood supply for the posterior medial papillary muscle. And then the way you differentiate with a septal rupture is, as I mentioned before, the time frame. Typically interseptal rupture takes longer than 3 days, and the murmur pattern. So with a mitral regurgitation, you auscultate the murmur best over the apex, and with a interseptal rupture, you will auscultate the murmur. It'll still be holosystolic, but best over the lower sternal border. An echo, you'll see. Sometimes this gets tested, so I just threw it in because it always confused me. But in the setting of acute mitral regurgitation, you'll see a non-dilated left ventricle because the left ventricle will still be able to have its normal forward flow with the ejection fraction. And then the left atrium will be non-dilated as well in the acute setting. And then you'll also see mitral regurgitation. Okay, so some more MI complications that should be more quick. So let's say you hear a friction rub 3 days after an MI. Yep, acute fibrinous pericarditis, post-infarction, treatment of that. So you actually want to avoid NSAIDs because it affects healing in these patients. So whole systolic colchicine would be okay. Yep. Whole systolic murmur over the apex, hypotension. This is the same case we had just a second ago, but I just want to put it in perspective. So what's this one again? And which papillary muscle? Yep, posterior medial papillary muscle rupture leading to mitral regurg. Treatment of this is emergent surgical repair. Now, 10 days post-MI, whole systolic murmur heard over the left lower sternal border, had a LAD occlusion. Good. Yep. Interventricular septal rupture. What can you see on cardiac catheterization? If they do like a right heart cath and the left heart cath of an interventricular septal rupture. So what will you see in terms of pressure in the right ventricle and oxygenation? So starting with pressure, will the pressure in the right ventricle be higher or lower than normal in an intraventricular septal rupture?
Higher.
Yep, pressure will be higher. What about oxygenation? Also higher, yep. So you'll have increased O2 saturation because you have left ventricular blood flow into the right ventricle, and then increased pressure as well. Okay. Treatment and surgical repair.
Yeah, one really high yield point about all of these, regardless, a lot of times you'll get a question, what is your best like defense against these things? What would have been your best method of preventing these things, like in the natural course?
Just treating them.
Yeah, so the right answer will be early revascularization. So that's why the door to balloon time is so important. Time is heart the same way time is brain with strokes. So getting to it early, really all of these are a result of ischemic tissue being more friable. So as the heart continues to contract, that tissue is just not as good as holding up against the stress as contraction as it normally is. So you start seeing these complications from that.
Yeah, the other thing to note is that I've seen this tested a few times, or I've been asked about this at least, is that previous MI is actually and hypertrophic cardiomyopathy is actually protective against like ventricular free wall rupture and we'll get to this one in a second, but ventricular rupture as well. So, all right, let's say you see a patient 14 days after acute MI, now has elevated JVD, distant heart sounds, you see electrical alternans. What are you worried about and why? And yeah, ventricular free wall rupture leading to, yep, cardiac tamponade. So on TTE, you may see cardiac tamponade. Let's say a patient has shortness of breath and lower extremity edema a few weeks after acute MI. Your physical exam is significant for a laterally placed PMI. You might also auscultate an S3 sound. What would be your next best diagnostic step? Which is often the correct answer in cardiology. Yeah, so usually you could pick EKG and echo, and it'd be a pretty good option. So what do you think the diagnosis would be? Yep, so true ventricular aneurysm. And you want to contrast that with the pseudoaneurysm, which is ballooning due to scar tissue, but that typically occurs earlier than a true ventricular aneurysm would. Okay.
Would it present the same?
It would present similarly, yeah, but you'd be able to differentiate with additional diagnostic imaging. Good. All right. So patient presents with chest pain that's worse with inspiration. You hear a friction rub with auscultation, but let's say this is several months after MI. So what is a diagnosis and what's the etiology?
Dressler's.
Good. Yep. Dressler syndrome, and that's an autoimmune fibrinous pericarditis. NSAIDs are okay in these patients. Good. All right. So now moving on to heart failure, one of the bread and butter diagnoses for medicine and very high yield for any board examination. So 65-year-old gentleman, history of hypertension, had a recent MI, now has 3 months of progressive dyspnea, dry cough, symptoms consistent with orthopnea. What is the diagnosis? Kind of give it away in the title, but yeah, congestive heart failure. Good. So what labs you want to routinely get in either acute or chronic heart failure?
BNP,
Good. So BNP,
basic cell labs,
creatinine, BUN, CBC, and then one more lab specific for heart failure. That's 3 letters. Or did you already say BNP?
Yeah.
Okay. For some reason, I heard BNP.
that's
Okay. So we'll get a BNP too and a BNP. Good. If they're in cardiogenic shock, you want to think about getting lactate as well. So what, just a quick side note, what is lactate a measure of? It's a surrogate marker for what?
tissue hypoperfusion.
Good. Yep. Perfusion. So well, if your lactate is high, are you perfusing well or poorly? Poorly. Good. All right. So acute treatment of congestive heart failure in most cases.
LMNOP.
LMNOP? I've never heard that. What's LMNOP?
Lasix, morphine, which is like, I think in nitrate, oxygen, and then position.
Okay.
No, maybe your M is, but it's probably metoprolol.
I agree with
No, I
think it is
Lasix.
I think it's morphine, but they're kind of like, eh.
I agree of the LMNOP. I agree with Lasix. So metoprolol, no. So you want to avoid beta blockers in acute heart failure exacerbation, and nitrates. Again, you don't want to be reducing their blood pressure, and sometimes these patients are a little bit preload dependent. So nitrates reduce the preload. O, oxygen. Oxygen, I agree with that one. What was P?
Position.
Position.
Upright.
Okay, position upright. I'm down with that. Okay. And then what other medication can you add if you're trying to diurese a patient, but they remain hypotensive and they have evidence of cardiogenic shock? What kind of medications do you want to add? What class of meds? So vasoconstrictors, good thought. So that's one way to increase the blood pressure, but what would vasoconstrictors do to afterload on the heart? Yeah, so you'd increase heart strength, vasoconstriction, increase afterload. So typically avoid that, but you will see it used sometimes in the ICU if they aren't able to keep the pressures up. But what other class of medications can be used to increase cardiac output and blood pressure? Yeah, inotropes. So, for example, like dobutamine or dopamine.
You use neprilysin inhibitors for acute
Neprilysin inhibitors. So what's an example of a neprilysin inhibitor?
chill valsartan.
Yeah, so Entresto, which is sacubitril, which is an ARNI. So that's an ARB with a neprilysin inhibitor. So you can use those. So that is one of the cornerstones of GDMT, goal-directed medical therapy. So we'll get there in a minute, but we typically will initiate that prior to discharge from the hospital. All right, and then some, just for general advice in taking a history in patients with CHF, some of the causes for acute exacerbation are the most common ones being medication non-adherence, especially with diuretics, diet, and infection. What's the main reason that a patient might not want to take their diuretic?
Peeing is annoying.
Yeah, so I've heard that one quite a few times where they don't like the sensation of having to urinate multiple times a day, so they hold their diuretic. So, all right, and this is, what is this chest X-ray showing? Yep, some cardiomegaly. Yeah, and pretty diffuse interstitial edema with some vascular congestion consistent with CHF. Okay. What's the most specific and sensitive exam finding you can find in a physical exam?
JVD.
So JVD, and so JVD is what you'll often hear, but there's one more sensitive and specific exam finding. and it's tied with JVD.
That's in the waveform.
Close. So what is another?
Jugular
Yeah,
reflex.
hepatojugular reflux. Exactly. So hepatojugular reflux measures the ability of the right heart, at least, to accommodate the extra venous preload.
I have also noticed quite a bit. I don't know if this is newer or what, because it's very difficult to actually pick out on exam. They could use that to show like a video of them performing that hepatojugular reflex and go that way. But an S3 on physical exam is often they'll say like what heart sound rather than an exam finding. An S3 meaning like a very dilated ventricle, and you're hearing all that blood kind of crash against the opposite side of the ventricular wall. Is also very highly specific for heart failure.
Very good. So I have a few more specific facts. What's the most common cause of right-sided heart failure? Left-sided heart failure in unison. Very good. What are the two main subclasses of CHF? HFrEF and HFpEF, right. So preserved ejection fraction and reduced ejection fraction. So a measure of diastolic dysfunction versus systolic dysfunction, respectively. There's also a new category, HFmEF. I have never seen it. I don't think it's very tested on the boards, but it's heart failure with moderately reduced ejection fraction. So that's also another indicate. You might get asked about that on the wards, indication for GDMT if they have clinical symptoms. Okay. What's the treatment of heart failure? We already kind of talked about this, but give me some GDMT medications. Lisinopril, yep. So ACE inhibitors are within the realm of GDMT, although ARNI is typically preferred actually. So Entresto has better outcomes data for HFrEF, at least for GDMT. What else? Beta blocker, good. What kind of beta blocker? Metoprolol. Have you heard of A-beam? The mnemonic A-beam. Tate, what does that stand for?
Those are the cardioselective beta blockers, which there are a few of them. But as far as GDMT is concerned, the evidence-based ones, there's actually only 3 that have been studied. So metoprolol, specifically succinate, not even tartrate. Succinate's the once-a-day form. Bisoprolol, which nobody uses, I've never seen it prescribed, and then carvedilol or Coreg, which actually gets used quite a bit because it has alpha-1 antagonism. So that's actually going to be your main one. Like, let's say you want to actually get some decent squeeze out of like blood pressure. Like this person has CHF and also has hypertension. You can get a little bit of that blood pressure reduction with Coreg, a lot more than metoprolol. But generally, metoprolol succinate is usually the most evidence-based as far as GDMT beta blockers.
Yeah, so usual dosing for metoprolol succinate, which is metoprolol XL. So that typically lasts for 24 hours, so it's once daily dosing. For tartrate, which is twice daily dosing. So metoprolol, usually we start at 12.5 or 25 mgs daily, but can up titrate up to even 100 mgs BID of metoprolol XL. With carvedilol, as Tate mentioned, it has more blood pressure effects. So usually you can start that up 6.25 mgs BID and up titrate as needed for blood pressure and if their heart rate has room. So usually just for inpatient, for anyone, doing their sub-I or anything like that, you want to put hold parameters, and you'll get asked a lot about hold parameters on beta blockers. So usually hold parameters I use are systolic blood pressure of less than 90 or heart rate less than 50 or 60, depending on the patient for beta blocker for rate control and blood pressure control. But beyond that, beta blockers are a medication you usually almost always continue unless the patient is has very, very, very hypotensive. Even in surgery, you'll usually want to continue beta blocker. Okay. And they'll always love to test about lifestyle changes. So salt reduction, less than 2 grams a day. Sometimes water restriction, stopping smoking or alcohol, monitoring daily weights. And then some 2 medications that are commonly tested that are help for symptom management, but have not been shown to improve mortality outcomes are diuretics and digoxin, which is not as commonly used, but digoxin is often a med that was used in the past for symptom management. So these are the meds that improve mortality. That'll be tested. The newest one is tested now is the SGLT2 inhibitor. So we'll start these in patients even if they don't have diabetes for reduction in cardiac remodeling. Okay. Some additional facts: life vest for severe heart failure or cardiomyopathy, given these patients have an increased risk of arrhythmia. And then after 3 months of aggressive GDMT, they can be considered for a permanent pacemaker if they have severely reduced ejection fraction. What's the most common cause of death in patients with CHF? PE, good thought. What can happen with a conduction system with a dilated heart? I think it's arrhythmia, yeah. So it's arrhythmia, and you think about anytime you have changes to the structure of the heart, you're stretching out the conduction system, which leads to aberrant rhythms. Risk factors of CHF we've talked about, and then some other risk factors to think about are alcohol, which often causes dilated cardiomyopathy, and cocaine or methamphetamine or sympathetic drug use can cause dilated cardiomyopathy. Okay, this is just a figure showing a typical initiation of GDMT within the hospital. So you can start typically with RAS inhibitor, such as ACE inhibitor, ARNI. Typically, we like to start with ARNI. So that would be like Entresto 24-26 mg BID is a typical starting dosing. Then beta blocker, such as metoprolol XL or carvedilol, MRA, like spironolactone, and then SGLT2 inhibitor like dapagliflozin. Notably, Entresto and dapagliflozin have some additional diuretic effects. So sometimes before discharge, you may have to cut down a little bit on the home diuretic. And then they'll see cardiology follow-up. Okay. A little more congestive heart failure, patient with longstanding COPD, OSA, now signs of heart failure. What is this brand of heart failure called, and what's the cause? Yeah, cor pulmonale. So some labs you can get, the standard heart failure labs. The cause, pulmonary hypertension, right heart failure. And this is important to note because it's an isolated right heart failure. So on the echo on the bottom right, you can see pretty severe right ventricle dilation, but relatively normal appearing left ventricle. So what that indicates is isolated right ventricle function, likely having to push against a pulmonary artery with increased pressures. So treatment typically involves diuresis, but again, no role for significant other GDMT. So this is something, this is what I wanted to get to, but what are the other types of pulmonary hypertension? So there are 5 major groups of pulmonary hypertension. This is one of the major pimp questions. Like in every rotation, they find a way to pimp on it. So group 1, what is that brand of pulmonary hypertension?
Is group 1 your straight up like? Yeah.
Yeah. Group 1 is
Okay.
exactly. Pulmonary arterial hypertension. Group 2 is pulmonary arterial hypertension due to not due to other lung disease, due to left heart disease. And then group 3 is pulmonary hypertension due to lung disease. And then group 4 is an interesting one. In patients that may have been, if they maybe have a clotting disorder, they may have group 4 hypertension, pulmonary hypertension. Yeah, good. Recurrent PE or microvascular occlusion. And then group 5 is unknown causes. So
I have seen a little bit of a mnemonic if you want to try to remember it this way. Obviously, for the people listening, can't really see it. Type 1, if you do 2 number 1s, you have kind of a blood vessel there. So that's actually like primary arterial disease. As far as 2, if you do a 2 and then another backwards 2 next to it, you have a heart. So you can be cardiogenic, pulmonary hypertension. If you do 2 3s next to each other, those kind of look like lungs. I don't know. Put a bronchus in there.
that's pretty
whatnot.
good. Yeah.
4, the way I was taught it was like you got a guy that was like sitting down and he's like crossing his legs over himself, like he's sitting on a plane. And he's got his legs crossed like this, and that's like your DPT into PE. And then 5, if you turn it upside
that
down,
is pretty good.
If you turn a 5 upside down, it's a question mark. So as far as ways to do it, because it is that you will not be tested on that on the USMLE for the most part. You'll have to identify pulmonary hypertension. But as far as like pimping question, That's very high yield, especially, group 2 pulmonary hypertension. And then now group 3, especially with like a lot more diagnosis of like obesity, hypoventilation syndrome, obstructive sleep apnea. A lot of people are actually kind of presenting with pulmonary hypertension type symptoms that are actually, for many years we're just garden variety heart failure, but then we're now kind of getting into this diagnosis more of lung disease causing all this stuff. So yeah, that's a good one. We can put a picture on that somewhere on the slide.
Yeah, that's good content right there,
That's
Tate.
good content.
We'll have
Thank
to
you.
make a YouTube short on that.
That's a short. That's right. That's good.
That's some short form
He's always
content.
thinking, man.
I know. All right, very good. All right, next cardiomyopathy. So the main two branch points when you think about cardiomyopathy are ischemic versus non-ischemic cardiomyopathy. So you often see systolic dysfunction in ischemic cardiomyopathy, and diastolic dysfunction in hypertensive cardiomyopathy. Right heart strain you can have due to pulmonary hypertension, due to these following reasons that we just talked about. So this is just kind of a good review slide that can help you discern in your mind what's going on in different forms of cardiomyopathy before we dive in. So let's say we have 55 years old gentleman presenting with shortness of breath, orthopnea, lower extremity edema. You hear a whole systolic murmur over the left fifth intercostal space, and there's a laterally displaced PMI on physical exam. No history of smoking, no ischemic risk factors like hyperlipidemia, hypertension, anything like that. Chest X-ray demonstrates cardiomegaly, and multiple members of the family have a similar presentation. So what brand of cardiomyopathy is this? From the exam findings. Correct, non-ischemic. Agree. Not obstructive. This is a step 1 brand question, but maybe seen on step 2 and maybe step 3. So the family history part is important. So hypertrophic is a good thought.
This is a tough
I
question,
have
Mike.
2 pictures. I have 2
It's a nasty
pictures,
question.
but I have 2 pictures that have a hint. So the top right, you see dilated cardiomyopathy, and the bottom you see the heart sarcomeres, which have proteins including tropomyosin, troponin, and titin. Now, I'll give you a hint. Titin is the implicated protein in this condition. So it's dilated cardiomyopathy, the inherited form of dilated cardiomyopathy, which affects the TTN gene, which codes for titin in the sarcomere. So what's the inheritance or most common inheritance pattern for this form of cardiomyopathy? Yep, autosomal dominant. And then what type of hypertrophy is seen with this cardiomyopathy? Eccentric. Very good. Treatment typically involves GBMT as well. This is essentially a half-ref picture.
This is another good place. Like in one like this is a very difficult question. Mike was not kind to you guys, but
I never
it
am.
never is. Yeah, very mean guy. But otherwise, this is a really good time where they like to put in either an S3 or an S4 in the physical exam. And S3 is more associated with dilated cardiomyopathy, just in terms of physiology. The reasoning behind an S3 is believed to be all that blood kind of hitting the back wall of a stiff right ventricle that's gone through eccentric hypertrophy, as an S4 is longer in diastole, and it's as that stiff ventricle is very, very full and it's not very compliant, and that's a keystone of like diastolic dysfunction. It doesn't relax very well, so it makes an S4. So if you can associate that in your mind as an S3 being more of a dilated cardiomyopathy and an S4 being a hypertrophic, I'm not sure if it's 100%, but in most questions that I've had, that's like one way that they try to steer you one way or the other. Because otherwise, you could say like, he's so hypertrophic that he has a laterally displaced PMI, or he has this big murmur because he also has concurrent valvular disease or whatever, rather than just, it's dilated and laterally displaced, and he has mitral regurgitation because the dilation is pulling his leaflets apart, which is what's happening here. But yeah, keep S3 and S4 in mind. They're very high yield. I've never heard one, so I don't know if
Really?
they exist or not. but-
I've heard them, but
okay,
I have a Littman stethoscope, not sponsored by the way.
not sponsored.
Anyways, I should have included S3 here. The way to differentiate this from hypertrophic cardiomyopathy would be first, the laterally displaced PMI is typically an indicate sign of dilated cardiomyopathy, and the second thing was the whole systolic murmur best auscultated over the left fifth intercostal space. So what do you think that murmur is from now knowing the diagnosis? Think about the kind of the anatomy of the heart. Yeah, this is my mitral regurgitation was what I was going for here due to stretching. This would be another good short form content video actually, because S3 and S4 are often confused, very high yield. But the way I think about it is S3, let's say you have an overinflated balloon and you put in a drop of water, even early, you'll hear that like resonation kind of, I almost think as like right as the mitral valve opens, you'll get that blood going into a very dilated or very filled up balloon with the blood. So you'll hear that sound first. Whereas with the S4, it's basically think of a really, really thick balloon that you can't really move very well. So when the blood or water rushes in for like a water balloon, you would hear the S4 sound.
It's difficult.
I don't know if that helps.
Short. We'll make a short.
We'll have to blow up
We'll
some
make a short.
balloons.
I
and
got this. I
explode
got this.
them.
Guys. We'll make a short. I got you.
Sloshing in S3 stiff heart.
Stiff heart. Yeah, there was one I watched that was like a stiff heart. And I'm like, I don't really, there's like one with like
Don't they do the syllables like
Mhm.
diastolic,
See, this is too. This
a
is just too
stiff heart.
complicated.
Slosh.
We'll make-
diastolic.
We'll make a nice
stiff
short.
heart.
We'll make a nice short on this. 'Cause
Yeah.
The way you guys are
Well,
confusing me. but-
me and Tate will blow up balloons in the resident room to the verge of explosion, and then
Yeah, that'll go well.
we'll get written up.
Sure.
It'll be great. All right. Anyways, moving on. So, what do we see in the EKG first of all? In the next set of inherited cardiomyopathy.
Spoiling stuff.
Very R wave.
Yeah, very
Tall.
tall R waves
Groovy one.
that meet. I don't know the name. I don't remember the name of the criteria. Anyways, evidence of what? What does that tell you? LVH, left ventricular hypertrophy. What about in the bottom right photo? Where do you see? What do you notice about the anatomy of that image?
Thick looking septum.
There is asymmetrical interventricular hypertrophy. Great answer, Xander. All right, very good. So you may also hear a holosystolic murmur on the left lower sternal border here, and I want to differentiate those because what's the murmur caused? What's the cause of the murmur in this presentation of cardiomyopathy? Exactly. This is outflow tract obstruction consistent with hypertrophic obstructive cardiomyopathy or HOCM. What genes are implicated in HOCM?
HCM.
HCM gene. Good guess. Good guess. So yeah, exactly. Myosin is involved. So
In both.
yeah.
So just know that one word.
So myosin binding protein C and beta myosin heavy chain are involved. And these are, again, protein filaments in the cardiac sarcomere. Treatment of HOCM. So what medication treatment? Yeah, beta blocker. Why are beta blockers so the kind of standard of care in HOCM?
Slow down the heart rate so that gives more time for the L-bot to get out of the way.
Very well said. So beta blockers reduce the heart rate and allow for increased diastolic filling, which increases preload for these patients. So it actually will increase the stroke volume. And of course, they always like to go after lifestyle modification. So also ceasing high intensity activity, beta blockers, or non-dihydropyridine calcium channel blockers. Sometimes implanted cardiac devices are indicated. And what type of hypertrophy is seen with HOCM? Concentric, very good.
Yeah, just to add to HOCM quick, because HOCM is extraordinarily high yield, especially when it comes to maneuvers on exam you can do to make the murmurs better or worse. That is good short form content right there that we need to add once again. But for the purposes of this side, first of all, for lifestyle modifications, ceasing high intensity activity, very true. That's like usually the story is you have syncope on high intensity activity. The reason for that is usually because the preload is decreased, both because of the increased heart rate with high activity as well as dehydration. So it's really important to keep these patients hydrated. And the beta blocker, like you said, you did a very good job of wording it. It makes sure that the ventricles have enough time to fill, because as the ventricle stretches and fills, it spreads the outflow tract further apart. So there's less of a chance that when it contracts, they touch together. Because if you have the septum and the ventricular outflow tract and they touch each other there, you cut off everything getting out from the heart. And that's why you have a syncopal event. You don't get any blood out, it stops. So knowing that is very high yield, as well as the maneuvers that make it better and worse. Anything that increases preload to the heart will make that murmur better, because you're going to be stretching that ventricle out more, which is what you should be doing. And then also knowing the associated echocardiographic sign, very high yield. Does anybody know what it is?
Mitral reflex, which is
Yes, and the specific name it'll be is systolic anterior motion of the mitral valve, or SAM of the mitral valve. It is extraordinarily high yield for this. I don't think there's a question bank on earth that doesn't have it.
I could think of a couple that aren't medicine related, but I agree with you generally.
The derm
Very
boards have
good. That's right. Very good. All right.
that.
All right. Anyone know what this is? Any budding
Oh, very good.
pathologists want to take a gander at what this image is showing?
green.
Apple
Whoa.
green birefringence with what stain? Congo red stain. This is a lymph node. Yeah. So
Very good.
let's say patient presents with dyspnea. I've kind of been using the same physical exam findings for every single patient, but that's because CHF often presents clinically very similar. So that's why, there's all this additional workup. But the 4+ protein in the urine is kind of the additional clinical finding that gives this one away, along with the histology. We kind of just jump to the pathology. Usually that's the last step. But this is a restrictive cardiomyopathy due to what? Oh, okay. Whatever. We knew that one. You guys got that one. EKG findings with restrictive cardiomyopathy. This can be seen with some restrictive cardiomyopathies. Oh, very good. Yeah, low voltage EKG.
Very high yield.
What type of dysfunction is seen in restrictive cardiomyopathy? Systolic or diastolic? Very good. I'm not a great poker player, I guess. Everyone's reading my facial expression. So yes, diastolic dysfunction, because it's similar to like a hypertrophic cardiomyopathy standpoint, where the lung or I'm jumping ahead here. The myocardium is less compliant to preload.
Yeah. Also, I'm gonna kind of forget what I was saying. Yeah. Oh yeah. What Mike said at the beginning was actually kind of a hidden gem. All of these symptoms are exactly the same. It is very important that as you get ready to take these standardized tests, that you recognize from the first like 1 to 2 sentences, this is a patient with heart failure. Done. Because then they're going to give you something like 4+ protein in the urine, and you're like, oh man, this person has heart failure and nephrotic syndrome. It limits the diagnosis very quickly. So in the same way, they could have said, he has, I don't even know what else, hypercalcemia, because sarcoidosis can also cause an infiltrative cardiomyopathy like that. And it's up to you to make a connection between heart failure, described in 2 sentences, and the finding of XYZ, whatever in the rest of the question. So just the test taking thing is just, it's the same thing with pulmonary embolism. They're hypoxic and tachypnic, and they're at risk for clots. He has a PE. Now what? So just test taking tip.
Spoken like a true test taker. But I will say one thing, even in clinical practice, has anyone ever watched like a radiologist read a CT? And they go, they're like, oh yeah, looks good. Or they're like, oh yeah, do you see that little nodule right there? So, the way that happens is just with pattern recognition. So when you see this pattern consistent with fluid overload, acute heart failure, you say, okay, now what's the cause of this acute heart failure or acute on chronic? And then you come up with the cause, and then you can say to yourself, well, this is consistent with ischemic cardiomyopathy, so that's likely the cause. But if you say, this picture doesn't quite fit run-of-the-mill HFrEF due to ischemia, what more could be going on? And that's, you can start digging for more details. And that's true of almost every diagnosis in medicine, is you'll have your bread and butter, but then you'll say, does this look like the textbook picture or not? So, the most interesting case in medicine aren't always the rare cases, but sometimes it'll be the abnormal presentation of common diseases, or not always just the zebras in medicine. So one of the most important quotes I've heard is like common things being common. So, as a med student resident, if you start off a presentation with that, most of the time the attending kind of will know where you're going, but then you'll want to think about other things in that situation. All right, rapid review of some more cardiomyopathies. Other cause of heart failure. So some endocrine cause of heart failure. What lab can you get if you're concerned about a non-ischemic cardiomyopathy?
Thyroid.
Good, thyroid. Heme. What can cause high output heart failure in particular? Anemia. Very, very confident answer. Yeah, anemia. So, if someone has a chronic anemia, they're going to need more cardiac output for oxygenation. Another thing to discuss really quickly is the difference between oxygenation and perfusion. So anemia typically is more in line with kind of oxygenation because your RBCs are carrying oxygen, and then perfusion has to do with the actual flow of blood to tissue. So that's why when you hear people talk about perfusion with like cool extremities, you can have warm extremities and still be poorly oxygenated. But the warmth is a good measure of perfusion, and same with like pulses. All right, cardiac tachycardia can induce heart failure. Social history. What kind of things on social history could lead to heart failure? What do we ask about? Good. Cocaine. Maybe not good, but correct. What is it? Sympatomimetic.
Very nice.
Sympatomimetic.
Yep, that's it.
Thanks, Tate.
You're welcome, man.
Sympatomimetic drugs.
Moving on.
Very good. All right. So what do we see here? What we have, let's say, you get the call from the ED and they don't have a history up. They don't have the H&P written, but you're looking through the labs and the imaging, and here's what you see. So start left to right. What do you see on the left?
The water balloon.
Yeah, it looks like a water balloon.
A little bit too on the nose, don't we think?
Yeah, that was a little bit jumping the gun. Cardiomegaly, resembling a water balloon. All right, the water balloon sign. I don't know the studies. I don't actually know if it's sensitive or specific, but it is high yield, and I do know that. That's a CT scan of the chest. What do we see on the CT scan?
Like some fluid around the heart.
So some fluid around the heart, specifically within the pericardium. And then with the third image, we have an EKG. Yeah, electrical alternans. Very good. So what is this consistent with? Good. What triad will I put on the clinical vignette? Beck's triad. What's Beck's triad? Muffled heart sounds. Elevated JVP. It's up there.
Is it the I think it's, isn't it?
Huh? Hypotension. Very good. All right. So yeah, if they're stable, usually you can do like a bedside ultrasound too. What's the treatment if they're unstable, especially?
Get that
Pull.
fluid out.
Pull something. Okay. Pericardiocentesis. Very good. Sympatomimetic pericardiocentesis. What are some causes of cardiac tamponade?
Free wall rupture.
Ventricular free wall rupture.
Post-MI.
Very nice.
Post myocardial infarction.
Very good.
Could you like purulence?
Purulence. Infection. If you keep listing organ systems, trauma. Good.
Cancer.
Malignancy. Hypothyroid.
Bleeding?
You can have hemopericardium.
There are a lot of causes, but not innumerable, but many. So infectious, autoimmune, neoplastic / malignant, trauma, thyroid, some medications. What derm medication? This is very low yield. This is a rare low yield moment, but I know we have some future dermatologists listening. It's for hair regrowth.
Minoxidil?
Minoxidil, oral minoxidil has a
Oh,
black
dude.
box label warning for pericardial effusion. If somebody gets tested on this, they should email me.
It's gonna be our 99%
And radiation.
trial.
Yeah, that's the difference maker. That and when I was in high school, there in European history, there was the nice to know versus the need to know. That would be it's not even classified as a nice to know. It classifies as extraneous information that you can pimp your med student on one day. All right, and you want to differentiate this from constrictive pericarditis. They can have a similar clinical presentation with elevated JVD, typically not the muffled heart sounds. What's the
You'll hear a pericardial knock.
pericardial knock? You will not hear it, but you may see it on an exam.
Yeah, yeah, no idea what that would sound like.
I talked with a cardiologist who's been practicing for like 40 years. He said he's heard one pericardial knock in his career. So, but they like to test it a lot, so you may see that.
Pericardial knock is constricted.
Yeah, pericardial knock is a
Specifically.
sign of constrictive pericarditis.
I will also say really quick, if you go back, Mike. So the pericardiocentesis is great in the acute setting. Sometimes they'll try to get people. It'll be tricky, especially in cases that aren't just like acute infection, acute trauma, whatever. This is like something like neoplastic syndromes, malignancy. These are recurrent pericardial effusions. So
What do
does
you wanna
anybody know-
do?
What would you do in that case?
Who are you gonna call?
I mean, so if it was
So
a new
what's the-
pericardial effusion, you can do fluid analysis on it and see if it's malignant, maybe.
What's the procedure you would do?
Who am I gonna call?
Who are you gonna call?
IR.
Always,
IR.
always call IR.
Close. IR is usually not wrong, but CT surgery for what?
Is it called window?
For a pericardial window.
Yep,
Yeah.
very nice.
So the way that works, you know how it works, Steve?
I believe it drains it down to the abdomen.
Yep, drains it down into the so basically you're you're allowing the pericardial fluid, which can accommodate significantly less fluid. Does anyone know in the acute setting, if you have an acute cardiac tamponade, how much fluid is required for tamponade?
I believe it's something really low, like 200 cc's, 250 cc's.
Yeah,
like
I
that.
think it was like, I think it's
Something
very
crazy.
low.
Yeah, very
Yeah, it's
crazy.
like whatever.
But if
200
it's chronic,
cc's.
like in the case of malignancy, that baby can get huge, and the heart can adapt over time. It can slowly stretch. But
Yeah.
if that happens very fast, like in the case of trauma, it's likely a game ender.
Yeah, it all
Tamponade's
depends on the
no good.
chronicity. But either way, yep, it
Very
drains
good.
it down to the lung pleural. All right, very good. What do
Wow,
we
I
see on
know.
this image? I got it from dermnet.org.
Are you a member?
Blue toes. If we add one more word to that, it's a diagnosis. Blue toe blank. Blue toe syndrome. What did this patient have done 3 days ago? Revascularization. Wow, very good.
Or
Wow, what a-
repair as well can be.
This was.
That's a
I'm
very
not gonna read that.
thorough history.
All right, it is a very thorough history.
That's how you.
Oh, that's because this is different.
Oh, you totally messed this
I
up.
kind of botched this.
It's all right. It's all right.
Not actually. All right, 70-year-old gentleman. He has a fixed amount of distance he can walk before he gets bilateral leg pain. What's your diagnosis? Okay, and what lifestyle?
Smoking.
Yes, you're gonna advise this patient to cease smoking. Smoking
Cease.
cessation.
You'll
Cease. Smoke if smoking cessation or alcohol cessation or alcohol withdrawal are answers, they're usually right. I don't think I've ever seen smoking cessation be incorrect, actually. All right. Very good. Graduate exercise program as well.
What's your differential for PAD? So you have leg pain that increases over time with movement. What are they gonna go for?
Neurogenic claudication.
Very nice. So what's the actual like pathology behind neurogenic claudication?
Disc herniation or spinal stenosis.
Spinal stenosis is the main one, yeah. So look out for that, especially if it's more positional than it is like time exercising. With PAD, the ABI is very high yield to know as far as like a value less than 0.9 in the ABI is diagnostic of peripheral arterial disease. If you ever get one, I doubt this would be ever questioned to you guys, but if you ever get a value that's less than 0.4, which is like mega low, it actually represents that there's calcification in those vessels and it's inaccurate. So you'd need to go do like a toe to brachial index and get around it that way. Been pimped on that before. So it's a weird thing. But the ABI is very high yield to know because in general, these tests, they want you to be very cost conscious, future physicians, right? So if the answer is conservative management or stop smoking, it costs $0 to do that. It really just a little bit of will and determination. Same thing with doing an ABI, taking somebody's shoe off and getting a nice ankle blood pressure on them. Doesn't cost anything, is actually very sensitive and specific for this condition. So anytime you see something that's very conservative, rather than just jumping right to the expensive big test, like I'm sure one of the answer questions on this case would be like CT angiography or digital angiography or something like that. Just always think like, how can I be more conservative? And if you think that there's a reason to not do conservative management, just have a good reason. Like if they're unstable or like their leg has 0 pulses in it, then you can go move on and do the invasive route. But otherwise, conservative is always better.
That's like the core of any exam, honestly, in medicine is usually start with the conservative options that'll be diagnostic, unless it's an acute life-threatening situation. In which case, I don't know if you've taken your surgery shelf yet, but
Stable or unstable?
the saying is if they're unstable, if you don't put exploratory laparotomy at least once on your exam, something's gone terribly wrong. You should go to the proctor and ask if you took the right shelf. Same with the OB shelf. If you didn't put pregnancy test at least 2 times, then you need to make sure you took the right shelf. Oh, and the pediatric shelf. If you don't say reassurance at least 2 times, then you didn't take the right shelf. It's like in have any of you played I play trivia at this place every week, and they have something called a free answer. So they give you the answer to one of the trivia questions. America Pub Quiz, yeah, that's exactly what it is. Anyways, that's kind of what those answers are on each shelf. It's like you're good for like 2 or 3 questions, but up to like 5 or 10 on each shelf. 10.
There you go. There's your question.
But anyways, cholesterol emboli, very good. All right. Oh no, I forgot to whatever. All right, ignore the bottom text. So on the left, you see left atrial thrombus, and then on pathology, you see mucoid.
Yeah, mucoid accumulation or myxoid tissue. Either way, really, it's more important that you realize that top image is like something or other that's taking up the majority of the left atrium.
So what cardiac neoplasm is that? Without looking at the bottom. Cardiac myxoma.
How did it present? Like, what did this patient have that brought them into the ED or whatever? Get this echo. Maybe, probably not.
Stroke.
Could be stroke. They do
Maybe.
embolize.
They do throw off emboli. That's fair. Most common way that's going to present is in your differential for syncope. It's going to cut off blood flow into the left ventricle for a second or two, and they're not going to have any blood that comes out just because of the way it falls into the mitral valve and the outflow tract there. So, yeah, syncope, make that on your differential, especially if they give you an echo picture, because otherwise, it's usually something else.
Very good. All right. The second one is just a cardiac met. Not just, but this is a cardiac metastasis. So the reason I included this one is because that's it's high yield to know that the most common cause of cancer within the heart is metastasis. And then the third one, don't look. This was going to be my challenge question. Say we have an infant presenting with a seizure and they get an echo and they see like a nodular growth within the myocardium. What is that neoplasm called within the heart, and what is the syndrome associated? All right, just say it. Say it. Don't worry, I have way more PIM questions for this. Yeah, good. Tuberous sclerosis with a rhabdomyoma. What is the nodule that they found on the head CT? They have ash leaf spots. Maybe we have a room full of budding dermatologists.
What's the full mnemonic for that?
I think it's hamartoma.
So
Yeah, hamartoma. It is.
oh,
I'm not a big
I have a video on this.
So
No.
Meningioma. Yeah, I'm not.
All right. Anyways, it's a subependymal nodule.
It's a Sega. You can go ahead and say it. SEGA. Like it's like a what is it? Subependymal giant cell astrocytoma or something like that. Something like that.
Either way, the finding on the CT is subappendable nodules is what they'll
There
see.
you go. Well, let's say it goes.
Either way, subappendable usually indicates tuberculosis. Why would we do a renal ultrasound in this patient?
Because it's part of the Hammertones. or the
That's right, it is part of the
Hammertoma,
acronym.
the acronym.
Now, what does that
Is it-
stand for?
Is it a renal, or is it a renal?
It is
Tip of your
renal.
tongue, you're doing very good. Let it roll.
Are they too big?
No.
Atrophy.
What's too big?
No.
Not atrophy. It starts with an A though.
Isn't it, what did you say?
It's a-
earlier?
It's a
No, you
hamartoma
said
of the kidney.
Renal angio, it's not an angiomata. It's
No, you're so close. Yeah.
renal angio something. Renal angio.
Wow, now
Angiomyolipoma.
yeah,
Renal
angiomyolipoma. So what an
There
angiomyolipoma is basically, so does everyone know what a hamartoma is? So a hamartoma is typically it's a benign growth of existing tissue. So for example, rhabdomyoma is a benign growth of cardiac tissue. So rhabdomyoma is oma of rhabdo. So myo meaning heart.
Do you know Latin? Yeah. You speak Latin?
I do not speak Latin. I barely speak English, but it's rhabdomyoma is like outpouching in the heart. Angiomyolipoma is blood vessel, muscle, fat. That's what's contained in nephric tissue. Very good. All right. Oh, skin finding. Ash leaf spot. What other skin findings? I have a soapbox about this. Maybe this is more short form content. What other cutaneous
Yeah, I
findings
didn't-
found tuberous sclerosis?
Yeah, I could not have seen this getting into a tuberous sclerosis review.
The random bumps of just.
Yeah,
random-
bumps is right. Shagreen
Shade green patches.
patches,
Ashley
but they're
said
not
it was
patches.
shade
They're plaques,
green plaques.
but they're called patches.
How dare they?
Anyways, enough of that.
Yeah, let's move on.
I'll link the dermatology review in the comments. All right,
Aye.
cardiac infections. All right, 35-year-old gentleman, 2-week history of shortness of breath, night sweats, fever, holocystoscopy auscultated over the left lower sternal border, and then painful erythematous spots over the fingertips. Infectious, i.e., infectious endocarditis is the diagnosis. What valve is likely affected in this patient?
Mitral, unless he's doing drugs, IV drug use.
So what's our answer?
Mitral.
What about the exam finding? Yeah, tricuspid, left lower sternal border, tricuspid area. I know. Yeah. Sometimes exam findings have a role. What organism is likely involved in this patient that has tricuspid valve, i.e.?
Staph aureus.
I think it's still Staph aureus. What labs are you going to obtain for this patient? How many sets of blood cultures? I think it's 3. You want 3 sets. We'll go over the blank criteria. Who did Wisconsin lose to in the national,
Oh, we don't want to.
the Duke's criteria?
It's 10 years ago and it haunts me.
Yeah. All right. Either way, TTE, then TEE to better evaluate valves. Base labs, CBC with differential. 3 blood cultures. Why do we get a UA?
They all, wait, never mind.
What are we evaluating for?
GI.
Glomerulonephritis is what I was going for. Due to infective emboli. And then here's the Duke's criteria. So the reason we get 3 blood cultures is because of, for diagnosis of, i.e., you need either 2 major criteria, or 1 major, or 3 minor, or 5 minor criteria. So major criteria being positive blood cultures, 2 or more blood cultures drawn 12 hours apart, or 3 or majority of 4 separate cultures drawn are positive, or evidence of endocardial involvement, usually on TEE, transesophageal echocardiogram is better visualization of valves. And then minor criteria, typically what you'll see in the question stem. So IV drug use predisposing heart condition like mitral valve prolapse, fever, vascular phenomena, immunologic phenomena, microbiologic findings. Does anyone know the mnemonic for endocarditis?
From Jane.
Yeah, it's from Jane. It's not, this one isn't quite as good to the Jones criteria, so I don't like routinely use it. But we'll go over it at some point. Yeah.
Question on just the valve that's infected. So I feel like I got a UWorld question wrong on this. That like, and I think why we were thinking mitral. Like I've seen something where if they don't have other risk, that like the tricuspid is just so associated with IV drug use. Like
I just didn't give you IV drug use.
okay, because I've seen like I had one where they were like, oh, people really actually only get an infected tricuspid if they have like IV drug use or something, and we don't see like, and if it's not, then
I was being a jerk on this one where I said, you know, you don't have the full history. So it was going to be based, the differentiating factor would be the physical exam finding.
Okay.
But yeah, typically they'll give you IV drug use. But I will say on shelf exam, on, you know, exams that you may take, you will see like vague answers that are based on Gestalt, or they'll give you other not like symptoms like this. So sometimes you have to look out for it. But yes, usually also with IV drug use. All right, treatment of endocarditis, empiric treatment. What does that usually involve? Vanc, good choice. And then that covers gram positive. So what? And I'm talking about an exam answer, not like a presentation answer. Yeah. What's a strong class of antibiotics that would cover gram negatives? So cefepime covers gram negatives. Stronger. More empiric.
They cause
Broader. Cause
hearing
hearing loss. Aminoglycoside. Which one in particular?
for exams.
Have you ever seen this on?
I've seen this. You're not crazy, Mike.
All right, I'm not crazy.
Nope.
All right, gentamicin is what I was thinking. Because you always look for the cephalosporin, because cephalosporin's like used for everything in the hospital, but on exams I think the official recommendation as well is vancomycin, gentamicin.
Empirically, sure.
All right, removal of intracardiac device, especially with staff. Long duration of therapy typically requires IV therapy, and it's an indication for antibiotic prophylaxis before like dental procedures if they've had prior endocarditis. It's even an indication for like prophylaxis before other procedures like GI procedures, I believe.
Depends. This is really into the weeds, and I don't think you'll get tested on it. The main risk factor knows if you've had endocarditis before, you need penicillin before your dentist operates on your teeth.
Or amoxicillin, right?
Or amoxicillin. Yeah, very similar. There is some guidelines, I believe. Don't take this as gospel, but in the setting of history of endocarditis, or even an artificial valve, which is an increased risk for endocarditis, if you are having a colonoscopy, routine colonoscopy, you don't necessarily need antibiotics. Even though, what's the pathogen you're worried about? If you have you're worried about the bowel and they have endocarditis. Sure, yeah. There you go. Yeah, strep bovis or galolyticus. But I think the research and I think the guidelines are that if you don't actually have like an active inflammatory process, or if you don't, or if you're not taking any biopsies, you don't necessarily have to run antibiotics for those patients before colonoscopy, like prophylactically. But if you do plan on taking biopsies, which usually you will, and if you don't plan on treating like anything acute, like you're doing it after a diverticular bleed or something like that, I do think you need antibiotics in those cases. Once again, you will not be tested on that, so don't take that too seriously.
Very good. All right. 15-year-old girl presenting with painful joints, new rash, shortness of breath, fever. On exam, you hear a new whole systolic murmur over the left fifth intercostal border, subcutaneous nodules on skin exam, and an annular, oh my God, and a rash. What's your further workup? What's your likely diagnosis? Why not? Why is it not rheumatic fever?
I don't know.
With the rash
The rash.
vertiginous.
What rash you get in rheumatic fever? All right, it is rheumatic fever, actually. Yeah.
Alright.
So, cause of rheumatic fever. Be very specific in the cause. So the bug and then like the response to the bug. What's the bug? Group A strep. And the actual cause is molecular mimicry. So examiners love to go after this is molecular mimicry of what protein in group A strep? It's a letter. That kind of scared me.
Who's got our answer?
Who's got a guess? Just guess the letter. M. It's the M protein. Yeah. So molecular mimicry, M protein. Very good. All right. And then major and minor criteria. So this is one of the best acronyms maybe ever. The Jones criteria. Does anyone know the Jones criteria?
Joints,
Joints,
heart,
heart,
nodules,
nodules.
the rash.
Yeah, what's the rash called?
Erythema,
Erythema marginatum. Very nice.
yes.
Yes, this is good.
This is a
good.
very good question.
They love to throw this one
Go
in.
ahead, say it out.
Yeah, S. Coriae
Sydenham chorea. Very good. And what is that?
Movement.
It's like spontaneous chorea or like what is it? Like movement or like
Yeah. Chorioathiform movements. So they're basically flailing, non-coordinated movements, usually of one extremity. So kid will present and they have like involuntary, like flailing movements of the arm. Should resolve with treatment, I believe.
yeah. All right. Treatment. What antibiotic? Old Faithful. Penicillin. NSAIDs for acute rheumatic fever, and then you can monitor CRP for resolution. And this is another indication for antibiotic prophylaxis for like dental procedures. Here's the AHA revised criteria for Jones criteria for rheumatic fever, carditis, arthritis, chorea, erythema marginatum, subcutaneous nodules. Very good. But then you can get things like CRP, ESR, polyarthralgia, get an EKG. All right. Valvular heart disease and murmurs. I know we already went over this, but basically the main ones. What do you hear? The left upper sternal border. Left upper sternal border is pulmonic stenosis, right? Or pulmonic auscultation area. What about the right upper sternal border? Aortic. Left lower sternal border. Tricuspid and left lateral fifth intercostal space. Mitral. Very nice.
Isn't there like also one that also like shows like aortic regurgitation?
Herb's point is in the second to third intercostal space along the left border. A lot of times it's more of like a aortic regurg, like it's on the path down. They'll never give you that on an exam, but you're absolutely right. Herb's point is left, second, third intercostal space.
What is that Herb's point for again?
It's like a second aortic listening post.
It's like
Very good.
I forget it's valvular aortic
Yeah, you're right. There's
I
something
have
to
read about that. Okay, what about this is very high yield if you're going to orthopedic surgery. The triple point. And what is the triple point? So that is an area of auscultation at basically the subxiphoid space or the lower sternal border midline, where the orthopedic surgeon are able to auscultate the heart, the lungs, and the bowel in one spot. Very high yield. All right. Next, going to shock. So if a patient is cold and dry, what type of shock is that? Hypovolemic. How do you treat that? I never know like if I put like treatment question mark and then IV fluids in the treatment or I just throw it in.
Seems like a slide maker's error.
Slide makers syndrome. Cold and wet with low. Well, okay. Cold and wet. Oh, that's right. There are two cold and wets. Cardiogenic shock. How do you treat it? Inotropes and what else if they're overloaded and wet?
Diuretic.
Diuretic. Okay. Cold and wet, but not cardiogenic. They're only. Oh, I didn't include neurogenic. All right, a different one, not neurogenic.
What's your the,
No oxygen.
the what's the
Yeah.
when it just
Hypoxia.
It would cause hypoxemia. What's one thing?
what's your distributive? Is that which one's the
Obstructive.
Bingo.
Nice.
You saved us. I didn't know how to.
I didn't know what I was gonna say. I was gonna
You
like
saved
say
us.
like PE, and
You
I'm like,
saved us.
I was gonna be like, yeah, what causes an elevated D dimer? And then the answer to that would be everything.
Very good work.
All right, treatment of that, relieving obstruction. All right, very good. Warm and dry. That's our distributive. What hospital problem causes distributive shock typically? Don't overthink it. Don't overthink it. Infection. Sepsis. All right. There's where you may see pressors. Does anyone know the resuscitation criteria for acute severe sepsis? No, resuscitation. How much fluid do we want to give them? So we give them fluids, but how much? This is a very high yield for residents. It's 30 cc's per kg. Typically around like 2 liters. Very good. All right. So again, let's say you get a call from, you're on your surgery rotation, you get a call from the ED. And you see these imaging findings. No H&P is in. What are you concerned about? Dissection of what? Aortic dissection. Very good. All right. Typically, these patients will present with severe tearing chest pain, right in the back, hypertension, and then asymmetric pulses. Every single one of these is very high yield. Sometimes they'll just give you one of them. But even with any one of these physical exam findings, aortic dissection or aortic aneurysm rupture should be on your differential, because severe 10 out of 10 pain, tearing chest pain right in the back, and then asymmetric pulses all are very are fairly sensitive and specific for this condition. Okay. Best diagnostic step for like a CT angio you can obtain, and then what other testing imaging can you obtain if they're more unstable? What kind of echo? I think it's a TEE. Yeah, in the OR. This is right, Tate? Is this correct?
I don't know on this one. I think you might be right. I've seen them choose TEE in the setting of chronic kidney disease because they don't want to give contrast to somebody with like end stage renal disease and you're suspecting it, but you still want to try to get a look at it.
The other thing is you can do TEE in the OR, so that has to be sedated for it. All right, how about we leave it at this? You can do a CT angio or a TEE.
Very good.
All right, treatment.
Surgery.
Surgery for which type of aortic dissection?
Oh. Type B.
Type
Type A.
Stanford B.
Stanford A. So
Oh yeah.
Stanford A. And you think of A for ascending. So that's the ascending port or the first portion of the aorta, ascending surgery. And then descending Stanford type B, you treat with beta blockers, BB. Stanford B, beta blocker. Stanford A, surgery. That one didn't rhyme as much. All right, pathophys of aortic dissection.
False lumen formation.
False lumen formation from an intimal tear. Very good. Well done.
Yep.
That's right. Also trauma.
Don't
As
click,
well.
don't click your button twice here. What,
And now I want to know, actually. What's a high yield fact?
Smoking.
I actually don't know what I was going to say.
What's
What's
the
the
mo-
most common cause of aortic dissection?
most common risk factor?
That's the most common
Maybe heritable.
Uncommon.
Maybe
one.
that's a very step one answer.
That's
but how
the
about
most common pimp question they would ask you. Trauma is close. What
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 hypertension?
lifestyle?
There you go.
Hypertension. Very good.
Very good.
The
It's
one right
hypertension.
there where it said due to hypertension versus.
Yeah. You know, these are all test taking. I'm training test taking skills.
That's
Sometimes
right.
you can learn how to
Sometimes
find
the
answers
in the
from.
question.
Yeah. Sometimes the answer is looking you in the face. Oh wow, this one's 65-year-old gentleman with history of tobacco use presents with mild abdominal pain, pulsatile mass on exam. Okay. AAA. What is the next step in imaging? Abdominal ultrasound. It's actually not a CT. All right. This is a surgery slide. It's in my surgery review, but I figured I'd include it here because it's pertinent and it can be tested because this can be screened for, and then that anything that can be screened for is and has a USPTF guideline, high yields for medicine and ambulatory shelf. So yeah, typically they recommend abdominal ultrasound with the following recommendations in terms of treatment. So greater than 5.5 centimeters typically warrants surgical repair.
I think yeah. And can't you get? Isn't there like a grading criteria for how fast it's going?
Yeah, there's a grading criteria for how fast it's growing as well.
Is it
Yeah.
1 centimeter? I don't.
I think it's 1 centimeter per
Yeah,
year.
or
Yeah.
5 millimeters in 6 months. That you know,
okay.
it's
The
up
answer
there.
is
Yeah, come on.
He's just advancing through it.
Come on. Come on. Come on. Come on. You know, these slides, I made them when I was sharp. I actually don't even think I made this slide. I think Quinn Steiner made it. I kind of just name dropped him, but he's an ortho resident now, big surgery guy. All right. These should be fast. Just I'm not gonna say anything, just yell out what it is. VFib.
Very nice.
All right, VFib shock. Ventricles are fluttering, weak contractions. Good. VTAC, good. Okay, you can shock if they're unstable or amiodarone. Yeah, very good. Amiodarone. I think what is it? 150 or 150
300,
mgs?
300 then 150.
It's 300 then 150. Yeah, that's the ACLS. So, all right, very good.
What's the other antiarrhythmic you can use for ventricular arrhythmias? So I quizzed Mike on it,
This-
and he didn't want to admit it, but this is sometimes an answer on tests.
I've never seen it tested, but I have seen it used, so it's good to know. It's a class 1B antiarrhythmic.
Lidocaine.
Lidocaine.
And it's if you look at your little ACLS card wherever it's at, I'm pretty sure it's on there. I forget what
I'm
the
sure
dose
it
is, but
is.
it's not as widely
know.
used as amiodarone.
I know the lidocaine drip dose. I think it's 6 mgs. I think, and then
I think it
6
is like a
mg
mix per
bolus,
chick, yeah.
and then it's or maybe it's 60. It might be 60 because then
seems
you
like-
could start a drip up to
That seems like a
4 mgs per minute.
good homework for the listeners.
All right, very good.
like intentional systemic toxicity.
Kind of.
What are you doing?
Well,
Yeah.
lidocaine's a class 1B antiarrhythmic. It blocks sodium channels.
Yeah.
So sodium channel blockade in the heart can cause like a ceasing of the electrical conduction there, the same way it does in your nerves. So that's kind of the pathology behind it. But yeah,
That's the rhythm.
Sounds good.
it's
Very good. All right. I asked one of the residents who's French, and I think it's Torsade,
Oh,
Torsade de Point,
yeah.
Torsade de Point. Me?
Yeah.
I'm not French.
I don't think so.
All right. Anyways, onwards. It means twisting of points in French. Yeah. Okay. Very good. Treatment: shock and magnesium if stable. Pathophys, long QT. What do we have here?
So prolonged QT.
That's a long QT. Okay. What kind of things cause a long QT?
Meds.
Meds? What else?
Can be
Genetic and electrolytes. All right. If a patient has long QT and sensory neural deafness, what syndrome does that make you think of?
Nielsen.
I think it's Jervil. Yeah, Jervil and Lange Nielsen. Very nice. All right. So common medications that they'll go after are tricyclic antidepressants, methadone, very high yield, antipsychotics, class 1A, class 3, azoles, opioids, mostly methadone, and antiemetics like Zofran and pro
That's compazine. Prochlorperazine.
compazine,
Prochlorperazine.
prochlorperazine.
Are those the same meds that would cause torsades? Or
Usually a long QT leads into torsades. So,
Okay,
so yes, it's the same kind of list. For the purposes of exams, TCA toxicity, class 3 arrhythmics, especially like not amiodarone. Amiodarone doesn't really cause it, but the other ones like diphenylide and ibutylide, sulfetylide, those can all cause long QT. And then they like to sneak Zofran on there because it's given so darn commonly. So before you, like when you're on your ED rotation, a lot of people will get an EKG if somebody comes in, they're like, oh, I've been nauseous, I've been taking a lot of Zofran, popping it more than the estimated time because you can get long QT from just Zofran itself. So that's how you as well.
Very good. Narrow QRS, tachycardic. What do we got? SVT, supraventricular tachycardia. Treatment. What's going to be the test answer?
What's your best next step?
What's the best next step? And then they'll say, well, you know what costs less money than adenosine? Vagal maneuvers. So the vagal maneuvers, ice water in children, and then carotid massage. That's actually not the one that's used ever, but that's sometimes seen on boards.
Usually
But
it's Valsalva.
usually it's Valsalva. So you have patients hold their nose and blow out or blow into a straw is what's commonly used. And then adenosine. I think that's 6 mgs. 6 mg push.
6 then 12 then 12.
Yeah, 6 then 12 then 12 mgs. And then what do you need? This is probably not going to be tested, but what do you need in the room when you give adenosine? Or what do you need the patient to have? You need to have pads. Yeah, because it basically causes temporary asystole and then restarts your heart. Very good. Caused by nodal reentry. Okay, what is this? What is that pointing to? Yeah, delta wave with Wolff Parkinson White syndrome. Treatment, procainamide. What class is that? What class of antiarrhythmic? Class 4. No. No. Say it. Someone say 2.
2.
No.
I'm all out.
Yeah, class 1. Class 1A to be exact. I was gonna have you keep going down. I was gonna say someone say 1, someone say 1C, someone say 1B. All right, either way, class 1A.
When they have test questions, you're gonna say class 1C.
Yes.
That would be more of a step 1.
But they will say like
Step
treat
2.
with a class 1A antiarrhythmic.
They could definitely say that. For WPW particularly, procainamide is longer than the classic one.
You'd be a great test writer. Anytime they would say, could this be tested? That would be a great thing to test. Anytime it's on the verge of what we want to study.
Very nice.
That seems to be what they throw in exams.
Yeah, procainamide's good. What's the big name side effect of procainamide?
Procainamide side effects. And what antibodies associated with this?
Well, that kind of ruins it.
No, it doesn't. Drug-induced blank.
Oh, lupus.
Drug-induced lupus associated with what antibody?
What antibody?
Antihistone.
Antihistone. Very good.
Yeah, that's also how you'll point avoiding nodal blockers in not atrial fibrillation in WPW, but AFib.
Oh, I meant in AFib with WPW.
Okay, yes.
So that's when you would give it nodal blocker. And
Yep.
So if a patient with Wolff Parkinson White has AFib, why do you want to avoid nodal blockers? So what's the mechanism of Wolff Parkinson's White? So it's not quite re-entrant because re-entry circuit is PSVT, but it's an accessory pathway of blank. Anyone? What's the name of Superman? Clark Kent. Does that ring a bell? It's the accessory pathway of Kent. So that's what causes the delta wave because you have an accessory pathway. Very good. That causes essentially pre-excitation. of that part of the ventricle. So you get the pre-excitation complex.
So if they were to ask you what's definitive treatment, there you go.
That's basically correct for most atrial arrhythmias. PSVT you can ablate, AFib you can ablate, A-flutter you can ablate, WTPW you can ablate. All right, very good. What is that?
Yeah.
No.
Oh,
There's
Yeah, it's MAT.
Oh, you're on left, a little bit left.
Oh,
right.
I see.
Yeah,
I
something
okay.
happened
I
here.
I didn't. All right. This is AFib with RVR. We all, how do we treat AFib with RVR?
We can just get through that.
Let's just fly. IV metoprolol push, sure. And then what else if not metop? Still ties them. When do you want to avoid DILT? If a patient has what condition? Heart failure. Very good. Okay. Chad's VAS score. Know that. DCCV, direct cardioversion if they don't have a thrombus. So if they've been anticoagulated for like 6 weeks, or you do a TE intra-op. Imagine you can do rate control or rhythm control. The old studies said rate control is equivalent to rhythm control for outcomes, but new data suggests that rhythm control may be better symptomatically and equivalent outcomes. So there's some rhythm control component. Now, this is ablation of pulmonary vein, risk factors. Anything that'll dilate the left atrium or cause like excessive stress, like in the post-op period. All right. Next, what's this? Good. Atrial flutter, sawtooth waves. Treatment, similar to AFib. Tricuspid annulus is the focus here. Sometimes I like to test where you ablate. So AFib, pulmonary vein, A-flutter, tricuspid annulus. The one way you can think about it, I guess, I just came up with this, so it might not be that good. But here you see like 3-to-1 ratio of waves, 3 tricuspid. But there's also like 2-to-1. So, but none of those are pulmonary. So, okay, what is this? MAT. Someone said it already. What's the criteria for diagnosis of MAT?
it's just different P waves, 4 different P waves or something.
Close. 3 different P waves, and I think you need to have tachycardia and irregular PP intervals. Okay, treatment of MAT.
Underlying
Treat the underlying cause. What?
Which is usually what?
COPD.
Here's COPD. What old COPD med? I called the digoxin of COPD was associated with MAT. You probably have never seen a patient on this medication.
I think I know it.
Yeah, you definitely know it.
I don't, but maybe.
It's dialyzable.
Theophylline?
Theophylline. Yeah. Very good.
Theophylline is an adenosine receptor antagonist. So if you, it's very similar to caffeine.
Yeah, so some people get like nervous and.
Yeah.
Use it for asthma too, right? They use the COPD.
Yeah.
It's old med. Yeah.
You have not seen a patient on it. I'll tell you that right now. Have you?
No.
Okay.
No, it's just on.
I was just kind of
yeah.
saying things.
Done.
All right. Either way, this is caused by a
Mike's
wandering
right.
atrial pacemaker. And basically what's causing this is there is a different foci in the atria causing each beat. So that's why you have a different appearing P wave. Okay. How much? I do have a lot.
Oh, you went off, man. Nice.
Yeah, I had a lot.
These are easy.
This is
Just
too
go ahead.
comprehensive. All right.
I'll be fast.
What kind of bundle block?
We'll stay till midnight if we have to, man.
Well, you guys can all leave. We're just farming content. Tate's got to go tomorrow, so we gotta get her done. All right. Which bundle branch block is this? Good. Left bundle branch block. All right. What about this bundle branch block? Right. Bundle branch block. Very good. There's like the way to, but basically with the right bundle branch block, you get the RSR, like the little r, big R. And I just remember like with the right, you get 2 R's. So like right bundle branch block, and you have little r, big R. All right. Very good. What is this? Prolonged PR. What kind of block? Type 1. You could probably guess the rest of these at this point. All right, and then
It's gonna be
2.
second degree Memphis type 1.
very good. All right, just for the audience, so first degree AV block, it's but typically benign if they're asymptomatic. Observation is okay if they're unstable. Can consider atropine, and the etiology is an intranodal block inside the AV node. Mobitz, the next one here is second degree AV block, Mobitz type 1, that has the prolonged PR interval followed by drop beat. Treatment of Mobitz type 1, Good. good. Observation also caused by intranodal block. If symptomatic, again, can consider atropine and pacing. Okay. Yeah, type 2, second degree AV block, Mobitz type 2, has consistent PR intervals followed by drop beat. This is usually treated by pacing, but new guidelines state that it's only treated by pacing if symptomatic, but on exams, typically pacing is the correct answer. Pathophys is an infranodal block, so block below the AV node. Okay. This one I always mess up on like a real EKG, but third degree AV block is complete dissociation between atrial pacing and ventricular pacing. So what's the typical rates for atrial pacing or SA node pacing? Usually about 60 to 100. And then what about AV node, intranodal pacing within the AV node? So like a junctional escape rhythm. Yeah, like 40 to 60. And then what about ventricular pacing?
30 to 40.
Like 30s. Yeah, exactly. So in these, you'll often see longer RR intervals with ventricular pacing that are longer compared to atrial P waves. Treatment of this usually involves pacing, but again, new guidelines state only if it's symptomatic. If somebody's in complete AV heart block, though, they basically are, a pacemaker is almost always indicated. All right. What is the first image? You would see tachycardia followed by basically asystole. So alternating bradycardia and tachycardia. SSS. Sick sinus syndrome. What's the cause of that?
Get old and things don't.
Yeah, it's essentially degeneration of the conduction pathways. Treat that with pacing. What is this one? This one's hard. This is actually a junctional rhythm. So if that's symptomatic, pacing's indicated, otherwise ablation. So the pathophys is that this originates in the AV node. So when the rhythm originates in the AV node, then it's the junctional rhythm. So there's junctional bradycardia if they're bradycardic, junctional escape rhythm, and then accelerated junctional rhythm if it's digoxin toxicity. It's a little more advanced. I don't know if I've ever seen it tested, but I've seen it a lot clinically, so I just threw it in. I think it is fair game to be tested, though. Okay. Very good. Cardiac meds. I think this is my last slide, fortunately. So calcium channel blockers. Which are the dihydropyridine calcium channel blockers? Nifedipine, nimodipine, amlodipine, clofidipine. All right, nimodipine, high yield things to know. Nimodipine used after what kind of brain bleed? Usually used after subarachnoid hemorrhage. Nimodipine. Nifedipine can be used if a patient is pregnant. Very good. And then amlodipine. All these dihydropyridine calcium channel blockers have what side effect? That's in about 10% of patients. Peripheral edema, especially lower extremity edema. Non-dihydropyridine calcium channel blockers. There's only 2 I included, but I think they're technically more now. Verapamil, AFib1, and diltiazem. Okay, nitrates. How do nitrates work? What? Oh, and yeah. All right. How do nitrates work? What vessels do they affect more? Which blood vessels? Veins or arteries? They affect veins basically exclusively. And that reduces preload to the heart, which is what reduces chest pain, because it basically reduces exertional angina. What medication do you need patients to not avoid, or what do you need patients to avoid? Sildenafil, very good. Which is a PDE5 inhibitor. Viagra, yeah. Usually we don't prescribe that in the hospital. In general. Statins, what do they inhibit? HMG-CoA reductase. This is a step one fact. HMG-CoA is converted by HMG-CoA reductase to mevalonate, which is a precursor in the cholesterol pathway. Okay, cardiac glycoside. It's a plant. Foxglove plant. Very good. What's the drug? Digoxin. Very good. And it inhibits sodium potassium ATPase. So it's involved in membrane repolarization and antiarrhythmic classes. Okay. Basically, the things to know with this class 1A, B, and C are like sodium channel blockers. Class B are beta blockers. So B, A in the alphabet, B is the second letter. That's class 2. And then class 3 are like amiodarone. I don't really know how to think of that. Like
We had a
class 3.
mnemonic and when we learned it, that was salty badger kills cow. So like your sodium, your
I've just always thought like if you write a K, it takes 3 strokes. Just
All right, if you
1,
write a
2,
K, it takes 3 strokes. And I guess salty badger kills cow. Sure. Very good. I dig it. It's silly.
it was a Wisconsin thing.
If I put a badger on the cardiac drugs, we'd all remember it. I'll do it next time. All right. Next is pulmonary review. Tate's gonna we're on switch spots.
Yeah, give your voice a rest. All right, so my name is Tate. I'll be kind of taking over the pulmonary review as well as the renal review. Really kind of the same format, going through trying to pick things out. I do like to deviate a little bit because really, in my opinion, the best way to study is like building these networks between just like a very structured question and then where they could go off of it. Because everyone can answer just like the textbook question answers. They're very important to know. That's what'll pass the exams. But doing very well comes from building connections between different concepts and being able to expand on them. So as far as first question here, 35-year-old Wisconsin man presents with several days of fever, shortness of breath, exam revealing inspiratory crackles involving the left lower lung base. Diagnosis. It says up at the top as well. Can I get very nice? Can I get rid of it? Yeah. So really, this would have to be based on a little bit of imaging. This is not my slide, so I don't know it that well. So aspiration pneumonia, predisposing factors to aspiration pneumonia.
Dementia.
Great. What about substance use?
Alcohol intoxication.
Incredible.
Anesthesia.
Very nice. Yep. So all of these things. Yeah. So alcoholism, anesthesia, dysphagia, which can be associated with like different kinds of dementia. Poor dentition typically means that you have, some sort of like bacterial load. So with aspiration pneumonia, it's good to keep in mind also like where they will tell you the infiltrate is. This one is just on the left lower lung base. That's fine. That could definitely happen. The posterior lobe of the right lung is very vulnerable to aspiration because, as you guys know, with like foreign bodies, the right bronchus is more vertical in nature. So you just have more likelihood of content going down the right bronchus to begin with. And then the posterior lobe is the most dependent of those lobes. So following gravity, that would be where that would be. Complications of aspiration pneumonia. Very good. So there is some here. And what's the treatment for aspiration pneumonia? Now, there's a couple ways to think about this. There's the new way and there's the old way. Some places are going to test the old way. So it's good to know it. But in clinical practice, we also do it a different way. So just antibiotic treatment. Sorry. You're thinking of the new way. So Gwen knows the new way of all this, like what actually happens in real life now based on really current research. But the old way to do it is to cover for anaerobes. So the logic behind this was as you are aspirating, these are GI contents. The GI contains a lot of anaerobic organisms as well as gram negative. So you better cover for them because it'll be different than the normal kind of distribution of like community acquired pneumonia pathogens. However, recent research has actually shown that most aspiration pneumonias are caused by the same things that cause community acquired pneumonia. So the treatment will not change. And we'll go over the CAP regimen here in a bit. So they might ask you, this would be one of the reasons they might ask you about clindamycin on an exam or on a question bank. In real life, clindamycin not really used that much, and why? What's it tied to? Its side effect. Very good. Yeah. So yes, and amoxicillin, clavulanic acid, or augmentin is a very common, and so is amsulbactam or unison are very common empiric regimens if you do want to cover for anaerobes. So they're good thoughts. It's just the reality of the situation is that most of aspiration pneumonia is actually caused by community acquired pathogens. So like your most common would, if they tested you on this and they were current, the most common pathogen overall would still be strep pneumonia.
Very good.
So community acquired pneumonia. Obviously, there's your case, several day history, pain, fever with deep inspiration, which would be called what kind of pain? Very good. Having that in your toolbox. Yeah. So pleuritic pain, very good. It's good to have in your toolbox because once again, this is something that like a lot of different pathologies would point out. So like somebody with a pulmonary embolism might describe pleuritic pain, and that kind of narrows your differential when you put all this stuff together. So cough productive greenish sputum, tachypnea, consolidation on the X-ray, inspiratory crackles involving the lower lung base. Best next step in this case will be chest X-ray. It's actually pretty decent sensitivity for pneumonia, and if it's negative, it actually provides quite a bit of information. Sputum gram stain, sputum culture. If you're hospitalized or have risk factors for those sorts of things like resistant bugs, where it actually will really benefit you to get a sample, that's great. In the outpatient setting, a lot of times it'll be a chest X-ray, and they're stable enough for just outpatient treatment. Most common bugs for community acquired pneumonia. Yeah, and I have my own slide about this, and this is gonna be a little bit of repetitive content. But strep pneumo, H flu, and then what's the other one?
More excellent.
Very nice. So like M. cataralis, Moraxella cataralis is also another common pathogen. In COPD patients specifically, there's a bug that's implicated a lot of times in causing exacerbation, so it warrants it warrants like extra suspicion on that part. I'll give it to you. So this is Haemophilus influenzae or H flu is highly associated with like COPD exacerbations. How about another one that I have a question on later and I have it written out better. So I'm scared. No, you saw it. Okay. Cases. Mike's just stealing all my content. This is my content now though. We're here. I know I overlap, but it's high yield. 43-year-old female presents with sore throat, cough, and malaise, very general, non-specific symptoms. On exam, she's afebrile, no tonsillar exudate, but does have like pharyngeal edema. What's our diagnosis here? Don't outthink the room either. That's something I do on exams. Strep throat, good on the differential.
H flu.
No tonsillar exudate. Tonsillar exudate's usually a strep throat thing. They'll give you that.
What's the criteria? What's the criteria called again?
Centaur criteria.
I was
I don't go over that because it's not that high yield, but it is pimped on in
I
clinic.
use it clinically.
Okay, sure. So the diagnosis here, I'm just going for viral pharyngitis. Most commonly, this is adenovirus. It can be any virus. Who cares what virus it is? The key is that it's viral, and the key is that your treatment.
Supportive vectors.
Very good. So it's very high yield. Once again, we went over how if the answer is conservative treatment, you better have a very good reason not to choose conservative management because honestly, going with that answer 9 times out of 10 will put you in a very good spot. So supportive care, hydrate, cough relievers, cough drops, whatever, and it should resolve on its own. So as far as things that support a viral diagnosis, cough, strep throat very rarely will present with a cough on exams.
And the center criteria, do you know how many points cough is?
-1.
Very nice.
Yeah.
And then without tonsillar exudate is also as well as afebrile. Usually when they're thinking you have a bacterial infection, you are febrile, you have pus somewhere, usually. And then in this case, no cough. Will be more of just sore throat. You'll see the exudate back there. Very good. So 50-year-old male now, 1 week of persistent congestion, sore throat, has a 2-day history of cough. A chest x-ray is obtained in clinic and is unremarkable. I've seen this actually get tested quite a bit more recently. I didn't necessarily have it on my differential and didn't know what I would do with it.
Gentleman, persistent congestion.
So he's had a week of upper respiratory infection symptoms, I would say, and then now he started to have this cough. Didn't mention it was productive, so it's probably not. And you got a chest x-ray and it's completely stone cold normal. It's a decent differential, and that one's very highly tested as well because once again, it's like conservative management. This is actually a pretty textbook presentation of acute bronchitis, also likely viral. So this one usually will follow a few days of upper respiratory tract symptoms. The way I think of it is basically this top presentation here, and then it settles into the lungs, cause inflammation in the bronchus, the central bronchus, but it's a virus. It doesn't necessarily like get and infiltrate on the chest x-ray or anything like that. So acute bronchitis, once again, what's the treatment? Very nice. And it's tough on this one, especially because a lot of times they will very much exacerbate this cough on exams. I've seen questions where they actually give them hemoptysis. So like, oh, you get scared and you're like, oh man, we need to do workup now. We need to do something about it. But they're otherwise totally stable. It'll be a very small amount of blood on a Kleenex or something like that. And then you'll be like, ah, this is probably actually just viral in nature. All right, so like I was just mentioning, viral infections are very high yield. Often conservative management is the right answer because we need to be good antibiotic stewards. Look for cough, rhinorrhea. The mention of a seasonal pattern is also very high yield. So influenza, probably the most high yield of the viruses. Winter months, vaccination is almost always indicated. If there's an answer on your test that is flu vaccination, once again, it's one of those where sometimes you don't really have to think about it. It's indicated in pregnancy. It's indicated in kids. It's indicated in anybody with like comorbidities because they're more at risk for severe infection. You really can't go wrong with a good old fashioned flu vaccine during the season, which is like October through May in the United States, or in the Eastern Hemisphere or whatever it works, however it
Would that
works.
be same for like immunocompromised? You could do the flu like shot, but you wouldn't do the nasal.
Correct,
Is that
yeah.
just
And same with pregnancy, you would avoid the nasal because that's a live attenuated form of the flu vaccine. So in theory, you could have reactivation and then have subsequent illness. Um, High yield point is oseltamivir or Tamiflu within 24 or within 48 hours of symptom onset, or if it's severe enough that they're in the hospital, they can get an antiviral too. So if you have somebody with just florid COPD and they're just a sick person, they have a lot of comorbidities and they get influenza and they actually get like a true influenza pneumonia, they're hospitalized for it. This would be a good time to give a oseltamivir, but also outpatient if within 48 hours. The problem with that is like who actually presents and knows exactly when their symptoms start. They're like, oh yeah, it was about 36 hours ago, doc. You're right. No one's gonna say that to you. So it's in real life, it's kind
Oh,
of tough.
one other thing about the Tamiflu is does anyone know like the classic like does anyone know the classic patient history they'll give you if for influenza? This is more of a clinical thing. So I've actually heard this several times, but they'll say it felt like I got hit by a truck. And that's just how fast the onset is. So you'll hear a patient being like, yeah, I was watching the football game on Sunday, and all of a sudden I felt like I suddenly got really sick and got really hot, and that's usually influenza virus.
Yeah, sick, hot, and then they also go after myalgias a lot. Influenza notoriously causes like a ton of muscle aches, so they'll just be like miserable in general. So here's a high yield case: 35-year-old man presents to the ED. Per his report, he'd been sick for about a week. Then he started feeling better. Then he started feeling much worse today, acutely onset. He appears ill. He's super febrile. He's hypotensive. Almost gives you a picture of sepsis. Notably, he coughs up a small amount of blood during the encounter. Yeah, he'd fit sepsis criteria, but that'll be for a different day. What's your diagnosis here? This is a classic vignette. They'll give you like a month. They'll say like in November. He'll present in November, which is flu season. So he had the flu.
They might even say like influenza test was positive.
Very
2
true.
weeks
They
ago.
might have given you. So he has the flu, and then now he got acutely worse. What's happening here?
bacterial infection?
Very nice. A secondary bacterial pneumonia. What's the cause? What's the bug most commonly implicated and superimposed?
No.
Staph aureus.
Staph aureus. Very good. Incredibly high yield fact to know it's Staph aureus, and it is. Yeah, I ain't lying to you guys, man. It's incredibly high yield. It's on every question bank. I've gotten tested on it many times. So knowing that is very high yield. Also, getting a picture of it being cavitary. So that's why we got hemoptysis, is because we're actually like destroying tissue with Staph aureus. So it's a very acute onset, very virulent organism, if you will. So very severe presentation is very typical for a Staph aureus. Especially in a patient that's just recovering from an infection, they're pretty vulnerable, so you get a more severe presentation. It's a good way to think about it. So now we have a 24-year-old male, 1 week of progressive fatigue. It's now very severe. He has cough, sore throat, fevers. On exam, he has pharyngitis, splenomegaly, gave it away, and posterior cervical lymphadenopathy also gave it away. His labs show transaminitis and leukocytosis with greater than 10% atypical lymphocytes. What is this? Very good. So I gave you every smacking criteria, but the idea is that you're able to identify just one of them if they were to give it to you. Splenomegaly, honestly, they're starting to give it to you less because everybody knows it. Posterior cervical lymphadenopathy is pretty decent. Greater than 10% atypical lymphocytes is starting to show up more, as is the transaminitis you can see. I've had patients like this. They'll have mildly elevated liver enzymes, and they'll give you that. So yes, infectious mononucleosis, that's secondary to Epstein-Barr virus or EBV. How do we diagnose it?
Clinical.
Probably is a clinical diagnosis, honestly. And what's the treatment? Exactly. So who cares? So really,
Avoid football.
yeah. So we'll go into that here in a second. Let's not put the cart ahead of the horse. But how to diagnose? Actually, the most sensitive and specific test is actually serologies. The monospot test is very quick. It can be done in the office, so it's a very nice test to try to get a hang of it. But there's also a lot of false positives, false negatives. Birth, like if the infection's early, if it's late. In certain patients, they just don't respond to it as well. So the serologies are actually like the gold standard for confirmation, because sometimes they'll say, what's your best first diagnostic test? And it might be the heterophile antibody or heterophile agglutinin test. But then if it asks what's your, most sensitive, or what's your best diagnostic test or whatever, I forget how it'll word it. And that would be serologies. So Mike already went into this a little bit. Anticipatory guidance. So what would you tell this patient before they leave the office?
No contact sports,
How long?
rupture spleen.
6 weeks.
I think the minimum is 4 weeks per the guidelines, 4 to 6 weeks to be safe. I know it. A lot of people don't necessarily feel up to playing sports within 4 weeks. Sometimes it's actually a pretty profound anemia, or a pretty profound like weakness. Okay, so now you have the same presentation, but all your tests come back negative. These are kind of send outs, the serologies, and they come back like 3 days later and they're negative. And you're like, oh man, he might not actually have mono.
What's the
I think
virus?
it's still
Yeah.
Incredible.
mono, right?
Incredible. This would be CMV, otherwise known as an infectious mononucleosis-like condition, is what you would say. Very similar presentation. This one you could actually treat if it got severe. Will you treat it in a young, otherwise healthy person like this 24-year-old male who presumably plays sports? Probably not. Now, what if he has a diffuse macular papular rash? And I kept the LOL in there because my derm friend commented on this. Yeah, he has a rash. What happened?
You gave him.
No.
Gave him the antibiotic. or it's
Bingo.
supposed to.
He probably took old antibiotics. Found him in the medicine cabinet. Little amoxicillin. Typically, it's an aminopenicillin. So amoxicillin, penicillin, one of the cephalosporins can cause it as well. That's high yield, and a lot of times as part of the presentation, even if they don't give you any of this junk, a reaction to an old antibiotic should kind of trigger that mononucleosis.
With Ian, we're starting with EBV, right?
With
Or
EBV.
CMV also?
I've never seen it tested with CMV. I'm not actually sure.
Usually
But
gives EBV.
Okay, that's a
Yeah.
A lot of viral infections, especially in kids, can cause a viral exanthem.
I don't know.
Okay, it's not.
No, it's not.
No, it should be good. Yeah, I can hear me. Am I just quiet? Do I need to hold it up to my mouth?
That was at 75, so.
Okay, yes. That way was muted.
Oh, well, we weren't.
Yeah.
It's no coincidence that we're flying. No, it's not talking. Okay, doesn't need to be mentioned. Next.
Bro, you're gonna be the first people watching this channel where they actually go to 0.5 speed. Everyone, they're gonna listen to me sound like a chipmunk, and for you, they're gonna slow you down.
I talk fast, man. I'm honored to go at 0.5 speed on medical student computers everywhere. It's the first time they'll have to go into their settings and everything. 20-year-old male. He has a 5-day history of nasal congestion and intermittent fever. He has pain to palpation of the maxillary sinuses. Very nice. Most likely diagnosis, viral rhinosinusitis. That's the start. So be very specific. Why not? Okay. So despite conservative management, which is indicated like we talked about, the patient continues to have symptoms. On day 11 of his symptoms, he comes back to the office and he has some purulence that can be seen on the exam of the nares. Very good. So could it have been bacterial the entire time? Sure. But a lot of times the treatment actually requires, I've actually seen it kind of stated, if the symptoms don't last for greater than 10 days or there's no frank pus on exam, you don't need to treat it like bacterial sinusitis because viral rhinosinusitis is so darn common. So really, you kind of conservatively manage. If the symptoms persist, you tell the patient. If stuff is still happening in 5 days, if you saw them on day 6 or whatever, give me a call, and then usually you could write a script for antibiotics at that point and feel kind of justified doing so. Okay, what's the most common risk factor for bacterial rhinosinusitis? actually kind of a floridly high yield point.
Floridly.
No, it's not. That's a good thought because what?
Similar to pneumonia,
Yep,
right?
mucormycosis is diabetes as a main risk factor, DKA.
It's-
Asthma's a
I'm
good
pretty sure
thought.
it's just viral.
Absolutely right. Viral URI is the most common risk factor. So a superimposed, and this is how test takers get you. You know, they're trying to build reasoning, and they're trying to tease out like if you're out thinking the room or not. And based on a lot of times medical students, myself included, are very good at outthinking the room. Like I'm like mucormycosis is an incredible thought, and that's because you've been studying for step one very well. And so you have that in your brain. But like a normal clinician who's never seen mucormycosis, it was just a distant memory in medical school, is more like maybe they had a viral infection first, you know? So a lot of these things are just kind of tailoring us to be more clinical. That's what step two is about rather than step one.
Very good.
Treatment.
Amoxicillin. Augmentin.
Great. Plus or minus clavulanate. You can probably get away with either one. If you have somebody with a pretty severe infection, maybe you add clavulanate and just feel better about yourself.
I think augmentin is usually empiric therapy though.
I think it is as well.
I read this on Up to Date recently, so I'm now
Okay.
up to date.
I doubt they'll make you choose between amoxicillin and augmentin on exam.
No,
That's
it'll
pretty
be
mean.
Augmentin.
Most common bugs overall.
It's gotta be staph. It's always strep.
Strep?
This is part of the CMOPS mnemonic as well. Sinusitis is the S at the end of it. So once again, strep pneumo, if you choose it, it's a pretty free answer on a lot of these for most common, especially out in the community with
Go
no
with
risk
CMOP.
factors.
That's another good short form one.
Yeah, so CMOPS would be the most
What
common,
is it?
like
C-
where.
So
Is this-
these three bugs are associated with CMOS.
No, specifically strep pneumo. Strep pneumo is the most common cause of CMOPS.
Yeah.
C being conjunctivitis. M.
What's M?
I don't know. P is pharyngitis.
Meningitis.
Meningitis.
What's O? Otitis media. Yep. The P, pneumonia, and S being sinusitis. So all of those, strep pneumo is highly indicated, and you're covering for that with what did I say? Indicated? No, implicated. Thanks, Mike. All right. Next.
Good job.
If I were a team, man. All right, 56-year-old man, past medical history, significant for hypertension, diabetes, and obesity, presents to the ED with 3 days of cough productive of yellow sputum, fever, and malaise. He's febrile, he's tachypneic, and he has decreased breath sounds over the right lower lobe. He has leukocytosis with a left shift on his intake labs. What does this guy have? Okay, and what's your next best step? We already kind of talked about it. Bingo. So diagnosis of pneumonia is basically a clinical diagnosis plus a known infiltrate on the x-ray. When you have that, signed, sealed, delivered, you have community-acquired pneumonia unless they have risk factors or some weird pathology going on underneath. Treatment? I'm going to spoil it a little bit.
Antibiotics.
It depends. For this patient, he has comorbidities. He has hypertension, diabetes, he's obese. He's 56, so he's getting there,
Bro.
he's got a few birthdays under his belt. That's just how it is.
Antibiotics.
So how are we treating let's say this patient is remarkably stable and he presented to the clinic and he has these symptoms and most
Outpatient.
Yep. So what are some choices? Because you're gonna need to know the choices.
Augmentin.
Great. What about like you can actually get a rolling with that. I wouldn't do it. I don't feel comfortable doing it, but it is indicated. You can do that. Or what other monotherapy could you use?
Respiratory
Close.
fluid.
You could, but also probably overkill. So here are your choices. In general, this is like a second generation.
That's right. You're a big doxy fan.
Second generation, Augmentin is good, both oral. Ceftriaxone would be a great choice if they had to be admitted and get IV antibiotics. Azithromycin or doxy, this is generally like the combination because he has comorbidity, so you need combo therapy. So you need one of these plus one of these. For atypical coverage, typical coverage. Fair enough? What if you only wanted to use one drug in somebody with comorbidities? So like this person. Mike already kind of spoiled it a little bit. No, not quite.
Respiratory fluoroquinolone.
Very good.
Let's go.
Very good. So respiratory fluoroquinolone, like Moxie or Levo, notably not ciprofloxacin. They might put that on there as a trick and make you choose between the fluoroquinolones. Moxie and Levo are considered your respiratory fluoroquinolones. They have better penetrance into the lungs. Okay, now the same symptoms, but it's a 24-year-old, no past medical history, healthy guy. I'm more saying about the antibiotics. We're still wearing antibiotics. So this is what Gwen was saying. You can get away. Actually, high dose of amoxicillin in these patients is actually okay. Because I mean, if you miss and it doesn't quite cover it, they're 24. They have plenty of reserve. You know, you're not making a life or death decision here for the most part. Doxy monotherapy can be done, or possibly azithromycin if your pneumococcal macrolide resistance is locally decent, which is like less than, like the resistance has to be like less than 25%, I believe it is. And that'll be based on your local antibiogram. If you've ever looked at one of those, they are pretty interesting. It'll show like in your region, how many strep pneumo isolates have they found that are resistant to macrolides. In general, back in the day, a ton of Z-Packs were given out for everything.
Back in the day.
Like even within the
You mean
last decade.
week?
Yeah. Well, and they still continue to be. But because of that fact, there's a lot of like normal garden variety strep pneumo bugs just flying around out there with macrolide resistance. So in general, that's why they like the augmentin more. Doxy is different and azithro, but it's all based on local prevalence as well. So you'll know that as you get into clinic and as you settle and find your practice and what kind of patients you're working with. Okay, well now what if you need to admit them and they're like septic, maybe a little bit unstable, they still have comorbidities. They don't necessarily have risk factors for resistant pathogens, but you need IV meds. What's your combo therapy for that? And not quite. Very good. IV azithromycin or doxy having atypical to typical coverage. The big thing here is just this is IV. These are PO. It's similar coverages. Ceftriaxone a little bit better on the gram-negative side, but augmentin does a good job too. Okay, love a picture. New patient that gives everything away. 65-year-old female on the floor starts fevering after being extubated for AE-COPD 2 days ago. She has a leukocytosis with left shift. She is more hypotensive and tachypnic now than she has been, and now she's using 2 liters of oxygen with the nasal cannula rather than room air, which she's been on for the last day. What are we worried about? Very good. So ventilator-associated pneumonia, which is a subtype of hospital-acquired pneumonia, requires.
Is that a Cardi B song?
No, it's not. VAP is not a Cardi B song for those listeners out there. You don't have to worry about that. All right. Empiric treatment for ventilator-associated pneumonia. Sure. What else? Sure.
Bank.
Sure. Basically, with VAP, we are worried about Pseudomonas and MRSA. We have to cover for them both because they've been in the hospital, and Pseudomonas likes a nice wet like surface, especially like an artificial one, like an indwelling tube or a trach or something like that. Pseudomonas is always kind of in the mix when it comes to that stuff. So empiric treatment is going to cover for both of those things. You got to have VANC for the MRSA. You get to choose piptazo or cefepime or meropenem, maybe. And then sometimes, never on exams, but sometimes fluoroquinolones or aminoglycosides might be added. These are patients that are extraordinarily sick and would warrant, you're worried about meropenem resistance. They exist these days, and sometimes you have to give aminoglycosides for that. It's a scary scenario if you're resistant to meropenem and like piptazo and cefepime, but it happens, unfortunately.
What about linezolid?
Linezolid is fine for MRSA coverage.
In the lungs?
Huh?
In the lungs?
Daptomycin's not used in the lungs.
Daptomycin.
Yeah. So Mike tried to burn me there, listeners.
No, I actually forgot the difference.
Yeah, so daptomycin cannot be used in the lungs, but it does have MRSA coverage. So why can daptomycin not be used in the lungs?
Because the surfactant.
It is inactivated by surfactant. So it just does not work on respiratory infections. But for skin and soft tissue infections caused by MRSA, sure, it's IV only, but it's a once daily infusion. So it's actually a decent choice for sometimes people who need like a PICC line for prolonged antibiotics. It's a decent choice.
Yeah, it's good for orthopedic, prosthetic joint infection.
There's the ortho bro coming out. Next,
That's right.
60-year-old smoker, fever, diarrhea, and a productive cough. He recently returned from a business conference where he stayed in a hotel. His chest x-ray shows no distinct lobar infiltrate, but he does have some diffuse interstitial opacities. No. Yeah.
I added that one.
Yeah. Busted, man. So Legionnaire's disease or Legionella. How do we diagnose Legionella? It's a urine antigen test. That's very well. You can send a PCR too, probably more sensitive and specific, but it takes a while. Urine antigen can pop positive in 15 minutes. So sometimes, yeah, I think it can. I think that's true. double check me on that, listeners. Expected lab on exams. They might give this to you, or they'll ask you to predict it.
It was sodium.
It's medicine's favorite topic.
Hyponatremia.
Look at that hyponatremia.
You said
If you have,
Sodium.
so in summary, if you have pneumonia with diarrhea and hyponatremia on an exam for medical school, this is Legionella unless they give you a test that is negative. And even if the urination test was negative, I'd still choose Legionella. All right. Treatment for Legionella. That's one of them. What's the other treatment?
My favorite antibiotic.
Fluoroquinolones.
Oh,
So
yeah.
fluoroquinolones and macrolides, and just also since you guys are in the realm of step one as well at the same time, how would you culture Legionella? What do you have to grow it on?
Bro.
Oh,
Conky agar.
No,
Not quite.
no.
It's
Hold on. Yeah, we know this.
It's a sketchy thing.
think about a
Is it?
minor.
Yeah, is it coal? No.
Buffered charcoal
Yeah,
yeast
something
agar
charcoal.
would be your growth medium for this. And then if you wanted to see it on a stain, how would you stain
Is
it?
there a sulfur or something too in there?
How would you stain it?
I don't know.
Silver stain. That's the answer to that. Once again, all step one, clinically relevant, probably not.
This is more high yield. This is very high yield. Because there's nothing more important in medicine than knowing like random facts. Like everything I do prepares me for when I'm a resident or attending and can just say random things. So if somebody has Legionnaire's disease, I let them know that this was named after a 1976 meeting in Philadelphia with the Pennsylvania State American Legion meeting, where many of the individuals, there's actually an epidemic, and they actually did a case control study and identified the exposure to I don't remember what unit it was. It was like the air humidifier. Led to it.
5-star rating. Patient satisfaction.
It was something involved with the American Legion.
Yeah, very good. Okay.
Oh, here's
So-
my next picture.
Yeah, love pictures that give away content. Very good. 25-year-old male presents with 4 days of dry cough. 4 days of dry cough, fatigue, and malaise. Young guy. He's tachypnic and febrile on exam, and his auscultation reviews diffuse crackles, all lung fields. Chest X-ray shows reticulonodular opacities. Labs show an anemia. Mild, but it's there. What's your diagnosis? That it is. So this is an atypical pneumonia. Most likely mycoplasma. Chlamydial pneumonia is also kind of presents very similar, but the anemia kind of does make a big difference here.
Whoa, don't skip over.
It's called walking pneumonia because
And I added a picture of an individual walking, the silhouette, very peaceful. In the black backdrop, of course. It almost blends in.
did you cite
It's
did you cite it?
beautiful. No.
Okay.
But anyways,
Is that you?
does that look like me? Anyways, with the walking pneumonia, it's individuals are typically don't have, they typically present with more mild symptoms that are, subacute or chronic symptoms with like kind of chronic cough or malaise. Not this guy had maybe 4 days of symptoms, so still in the acute category, but
Very
yes,
nice.
very good.
Treatment, and I kind of spoiled it. I forgot I had another click there. So macrolide, doxy, or fluoroquinolones. These are like typically what you would consider like antibiotics to cover atypicals. And when you say that, this is what you mean. So treat it with a macrolide or doxy or fluoroquinolone. He has anemia, but why? Very good, and actually kind of high yield. So, and it's hemolytic. It's IgM mediated cold agglutinin hemolytic anemia. You'd expect your like high lactate or lactate dehydrogenase LDH and your low haptoglobin also on labs, because a lot of times they'll ask you, what lab would you predict or what lab value would you predict or something like that. And in this case, it's nice to know that he's having a hemolytic anemia. Usually it's self-limited, not going to cause many problems, but interesting fact, and it's high yield because mycoplasma is actually very common, especially younger people, close contact. So like military barracks is classic. All those like close contact areas, goes through schools and stuff like that. 45-year-old female to the ED with hemoptysis fever, weight loss, also has night sweats over the last week. She emigrated from Southeast Asia. Your exam reveals decreased breath sounds over the left lower lobe. A chest X-ray finds a granuloma and an associated infiltrate in the left lower lung, along with hilar lymphadenopathy on the left side. What's your best next step?
Chest X-ray. Oh,
It's a
wait,
great
I
guess
did
because
that.
I've conditioned you to say that.
Airborne precautions.
Absolutely. This is airborne precautions because why? What are we worried about? This is TB, especially and even in the case like this might not be TB, this might be something else, but you have somebody that's high risk from an endemic area, has the right symptom morphology. We're putting them in airborne precautions before we, do anything else. How are we treating TB? Very high yield to know how to treat TB.
Right.
Ripe therapy. I always say it's 4 for 2, then 2 for 4. So ripe, all 4 agents for a total of 2 months, and then you'll transition to just rye or 2 for 4 months. So now the ever high yield TB treatment side effects, because they come up all the time and they're very interesting. Rifampin, what do we expect?
Is that the orange pea?
Orange pea is great.
It's great.
I even kind of
That is
colored it
correct.
orange. How about that? A CYP 450 inducer as well, so it messes with a lot of stuff. Rifampin, especially one of the high yield things. I don't know if it's actually high yield for exams. I think I've actually been tested on it. If you have somebody with HIV and they get TB, so weird situation, but those people are very dependent on their meds. If they stop taking their retroviral therapy, or if anything messes with it, they're in trouble. They get immunocompromised very quickly. So you don't use rifampin, you actually use its cousin rifabutin in those patients. So that's actually kind of a little high yield point, and this is how you gain points on exams, is knowing stuff like that, where it's like, is that super crazy to know? Like you have to know it? No, but it's something that's very relevant in those patients' case and could be like a life or death decision if they were to have a flare of their HIV at the same time.
More importantly, you can pimp people about it.
Yeah, just like I just did.
That's right.
How about INH or isoniazid?
That one does something bad.
What vitamin is effective?
B6.
Great. So you always have to supplement with B6 because you get deficient. When you get deficient in B6, what's your main symptom?
Is it pellagra?
Not quite.
Right there.
That's B3.
Okay.
Niacin deficiency. B6 deficiency, most common symptom is actually a peripheral neuropathy.
That's okay.
So they'll have a peripheral neuropathy. And then what's the other cause? We already
Well,
talked
I mean,
about
that's
this.
right.
We already talked about this once, but isoniazid falls in the same group as procainamide as drugs that can cause drug-induced lupus. Very good.
Very
So
good.
good to know these as
Doesn't-
well.
Doesn't B6 deficiency also cause an anemia?
It does. Sideroblastic anemia specifically.
Oh yeah, that's right.
But on exams, they usually give you the neuropathy because that would present first, with symptomatic, like they'll start feeling the tingles and stuff like that. But also very good points. B6 being sideroblastic, not many things cause it. How about pyrazinamide? Gout or hyperuricemia. And then quite possibly the most high yield for whatever reason, ethambutol.
Yeah.
Optic neuritis and associated red-green color blindness is the most common, sequela of that. Yeah, so those are very high yield to know. All right, now you have a farmer from Wisconsin. You can tell where this is going. He has fever, cough, and he has painful bumps on his shins, and he has hepatosplenomegaly on exam. What's his diagnosis? Incredible.
Erythema nodosum.
Yep, this is his erythema nodosum. The differential for erythema nodosum is worthy of short form content. So we can talk about that later. It's everywhere. Erythema nodosum is very common. Also, narrow-based budding. If you were to see a picture of it, once again, that's step 1, not step 2. But
You
we'll
know the most
contrast.
common cause of erythema nodosum? 50% of patients. Idiopathic.
What a derm fact. All right. Best next step in evaluation of histoplasmosis. How would you go about trying to diagnose it?
Histo.
The urine antigen?
It is indeed. What a great answer. Yes, a urine antigen test is the best next step there. You can also do fungal cultures, notably, and try to put it on a slide and stuff like that. But as far as quick and easy test, urine antigen is good. Okay, spring break in Phoenix. And now he has a cough, fever, night sweats, and painful nodules on his shins. Once again, very common. Coccidioidomycosis, valley fever. Classically has erythema nodosum. You'd see spherules on your little culture. So just like a little ball of little tinier balls, I suppose, is what you see. I always think about it spherules. There's a lot of spherical letters in cocci. C zeros like C O C C D O again O again O again. A lot of spheres going on. So just imagine that. Now you have an immigrant from Ecuador, ED with painful mucosal ulcers or even mucositis, cervical lymphadenopathy, and really gnarly skin
Bro,
lesions.
you just gave up on describing skin.
Is gnarly gonna be the question?
I could describe them if I wanted to, but that's how.
Like
But I will tell you that's how important I view skin lesions. So let's say he has these skin lesions. I consulted derm. I don't need to worry about it. Painful mucosal ulcers as well. So what is this diagnosis? Paracoccidiosis. Very nice. And then what does it look like if you put it on a slide? Captain's wheel or ship's wheel. Very nice. How about a 50-year-old male in Ohio? Fever, cough, raised skin lesions. Once again, very detailed dermatologic explanation. Pain in his back, ribs, and right femur. Very nice.
Okay, Blasto called Ohio.
Yes, I think it is blasto is Ohio Valley fever. I'm not 100% sure on that. And what would you see if you put this one on a slide? Good alliteration, yes. So blastomycosis causing broad-based budding is very high yield as well. Okay, treatment for all of these. Okay, specifically?
You put them on the.
Not quite.
If they're in the hospital and they're bad. Yeah, amphoterapy.
Okay, that's if it's systemic and severe. But what if you're just, they come to clinic, they're actually doing pretty well, but you find out they have fluconazole. You can use diflucan if you'd like. You can also use, usually on exams that I think is getting tested more, is itraconazole. But an azole, and remember, azoles are kind of high yield. They're QT prolonging agents. Sometimes they'll go after that. They're also CYP. They also mess with the CYP enzyme system, so they can go after that as well.
If you want to talk about side effects, let's talk about amphotericin.
Yeah, amphotericin causes a lot of side effects. I didn't go into them because a lot of times it's electrolytes, kidneys, stuff like that.
Liver
toxicity. They're very toxic medications. That's why they don't get used unless it's severe and systemic in nature.
Okay, so Ohio Valley fever, according to the internet, is histo.
Okay, so
I believe that.
okay, so Ohio Valley fever is actually histo per the internet.
Per the internet.
I believe it.
Okay, I believe it as well. I believe it.
But the thing that's associated with like Ohio
River Valley is blasto.
Blasto.
Yeah, very
Ohio
confusing.
River Valley is blasto.
Remember when I
and
said?
then
Remember when I said?
Mississippi is histo.
You can quote me on this. Don't outthink the room. It's very high yield. Very high yield. Don't outthink the room. You'll know it's histo or blasto by them talking about bones or hepatosplenomegaly.
What they usually give you, honestly, with blasto is a skin lesion that looks like skin cancer but grows fast, and so
I would describe it as varicose.
So there are a
Verrucous?
few different. If we want to get in the weeds, there are a few different morphologies of blasto. There's an ulcerative subtype that looks like kind of ulcerative basal or squame. There's a hyperplastic or a hyperkeratotic subtype that looks like squamous cell, and then there's a verrucous as well.
Very good. I forgot this was.
But yeah, they look like skin
derm review.
Hey, I mean,
No,
it's
it is
fine.
very interesting, and
All right, very good.
the skin lesions are very high yield in these, especially with blasto being more so than histo. Histo will be the EN, blasto will be like more of the actual, like they'll show you a picture of a skin lesion that looks bad.
That looks bad.
It does.
That looks hyperkeratotic
There
or
you go.
ulcerated.
Great. All right. There's a lung. Let's spoil something. Oh yeah, I guess that doesn't spoil it.
Doesn't spoil
All
anything.
right. 50-pack year history of smoking, older guy, COPD, hypertension, type 2 diabetes, colicky right flank pain and hematuria, and he has hypercalcemia. Is it small cell? Squamous cell cancer, squamous cell carcinoma of the lung. Very good. What would you see on pathology slide of this? Keratin pearls and?
A lot of pink. No.
A lot of pink is very true. A smoma body would also be expected in squamous cell. You can see that. Keratin pearls is
I
also
haven't
very good
thought
though.
about that in a long time.
Yeah, you're a few years out of step, man. A few years.
What
All
else
right.
has more about meningioma and like
Meningiomas
is
have-
it medullate papillary? Is it or medullary?
Papillary thyroid cancer.
Papillary.
Yep.
That's enough of that.
Next best step. He has squamous cell cancer. At least you suspect he has squamous cell cancer. What's your next best step?
Chest X-ray.
Quit
Yeah.
smoking.
Incredible. Quit smoking is a great piece of advice. Chest X-ray is great for initial workup. In real life, would they likely go straight to CT? Maybe, if your suspicion was high enough, like if they had lost 20 pounds in the last month, or if they were having hemoptysis actively. So even if it was an infection, it's probably cavitary, so you want to get a look. Probably, but a chest X-ray on exams is going to be your next best step. Now you want to evaluate their hypercalcemia. So, like, what level would you expect to be high to differentiate from other causes of hypercalcemia?
This is a good one.
PTHRP.
Incredible job. PTHRP or parathyroid hormone related peptide will be elevated in specifically paraneoplastic hypercalcemia of malignancy. So other cancers can do this. Squamous cell of the lung is probably most common on exams causing. Oh dear. 60-year-old female. he's mewing.
Actually, there's a slide later on where I was gonna put the mewing thing, but I couldn't find a good one.
Okay, so female with 50-pack-year history of smoking, COPD, hypertension, diabetes, basically the same stuff. She had a fall and she broke her hip, but she reports this month-long history of lethargy, weight gain, weakness. On exam, she has a buffalo hump and increased hair growth on the face. And then you have a central nodule on chest X-ray. What's your diagnosis? Very nice. Small cell CA of the lung. You already did the X-ray. Very nice. With paraneoplastic Cushing syndrome or ectopic ACTH production. Other syndromes you can have, SIADH is very high yield. They'll present with hyponatremia. Lambert-Eaton myasthenic syndrome, so they'll contrast that with myasthenia gravis. Remember, Lambert-Eaton will get better with repeated use. That's kind of your big thing, and that's an autoantibody to voltage-gated calcium channels, because they also high yield phrasing of those. Bonus. This is for an internal medicine nerd. Which test would be negative and support a diagnosis of ectopic ACTH production rather than it coming from the pituitary?
Which Cushing's disease test?
Which one? Low or high dose?
High.
Very good. The high dose dexamethasone suppression test. So low dose dexamethasone suppression test is one of the initial diagnoses for hypercortisolism in general, or like to get the diagnosis of Cushing's. To localize ACTH, use the high dose dexamethasone suppression test. So basically what that does, and this is how I've always thought about it, a high dose will suppress anything that is supposed to be suppressible. So even though in a pituitary adenoma secreting ACTH, it's not supposed to be happening, it still is native pituitary tissue and knows how to respond to high doses of steroids by being inhibited. The feedback isn't completely lost. The lung doesn't know any better. This is how I'm thinking about it. The lung cancer doesn't know any better. It's not affected by the normal regulatory mechanisms. This is an acquired, mutation or whatever ability of these cells and not responsive to the normal negative feedback loop. So very good. That is honestly knowing the workup of hypercortisolism and Cushing's is pretty high yield to know. Here we go. That's good. Progressive pain in the hands and dry cough. She's never smoked before, but on exam there's clubbing of the distal phalanges. Chest X-ray shows a large pulmonary nodule. Most likely diagnosis. Lung adenocarcinoma, very common more common in women, more common in non-smokers specifically. Where would that chest X-ray nodule be located? In the periphery. Very good. So I'll cite Dr. Sattar, who is a hero in the field of medical education.
The goat.
If it starts with like squamous or small cell, they're centrally located. Other ones like large cell and adenocarcinoma and even like large cell are all, I said it's large cell already, but yeah, all the other ones are more peripherally located. So what's going on with her hands? Because they're painful, She's clubbing.
Chronic hypoxia.
Okay, that's one of the reasons. But actually, there's a really common pathology. I shouldn't say really common, but a more commonly tested pathology that's coming out now. That's kind of presenting like this, and they want a specific term for it. And I don't know if you guys have seen it yet. Very common.
Hypertrophic osteoarthropathy.
Hypertrophic oh my goodness, Dr. Gui. All right, consider it a paraneoplastic syndrome actually. So this is clubbing. Clubbing also is seen in people with like cystic fibrosis, primary lung diseases, chronic hypoxia. So it's a great thought, but specifically when associated with cancer, it's considered a paraneoplastic syndrome, this like outgrowth of bone. I'm not sure the pathophys behind it. It's one of the things I will not answer, but yes, knowing that term specifically, hypertrophic osteoarthropathy, and then like I said, you'd expect a perfect. All right, so let's go into the meat and potatoes of pulmonary, which is like obstructive versus restrictive disease, and like what do we do about those pathologies, which are actually the ones that are common and land people in the hospital quite a bit. How do we characterize obstructive diseases? What are some things you know about obstructive disease? Great, 0.7, great. The main one is 80% here. I'm not sure who put that in there.
That was me.
I meant to
Examples?
say 70.
Examples of obstructive disease. Great. What else? Awesome. How about going to the weeds? What are the other ones?
What about chronic infections? Chronic infections.
Emphysema is an obstructive disease. It's part of COPD, and both chronic bronchitis, both chronic bronchitis and emphysema are both obstructive diseases. And emphysema has more causes than just COPD. So you can have it with alpha-1 antitrypsin can cause an ACE or very nice. Yeah, so you know it. Examples, there you go. COPD, asthma, bronchiectasis, repeated scarring of the airways. Physiology is obstruction of airflow, repeated air trapping. So this is when you have a barrel-chested guy, increased AP diameter, stuff like that. So let's go into our case studies. 40-pack year smoking history, hypertension, hyperlipidemia. Get that out of here because I can't read it. Now he has like increased cough, productive of yellow-green sputum. He recently had exposure to his son who had rhinorrhea, fever, and malaise that resolved spontaneously. His physical exam significant for decreased air movement, prolonged expiratory phase, and diffuse bronchi bilaterally. It's a pretty detailed case.
I
Diagnosis?
don't even remember.
It's worse over the past
Is this
several.
COPD exacerbation?
This is just
I think
COPD
I wrote this,
exacerbation.
actually.
Yeah, you know, you probably did. It wasn't me. All right. Cardinal symptoms of a COPD exacerbation. What are the things you ask the patient about to like say like, is your COPD actually exacerbated right now?
This is more of like a pimp question.
It is.
Have increased cough.
Cough.
increased yeah. Cough,
Sputum.
dyspnea, sputum.
Dyspnea. Change in your dyspnea or cough. Increased sputum is very high yield for exams. Increased cough. A lot of times, the patients that I've seen with AE COPD, they know it. Like, yeah, 3 days ago, everything got acutely worse. Like, it's not my normal cough because everyone here will usually have like a smoker's cough and like, oh, I cough all the time. This is different though. More sputum. Treatment?
ABCs.
What does that mean? I've never heard it.
Antibiotics, bronchodilators, and corticosteroids.
Wow, very nice.
I
Okay.
haven't heard this many acronyms.
Nope. That's what all the kids. That's what all the kids are about. You got to be cautiously aware. Okay, so duonebs. You're doing that in the hospital. That's a combination of albuterol and ipratropium.
Oh, I forgot the ABCO oxygen.
Oh, and
Sorry.
oxygen. Yep, as needed. So duonebs. That's a SABA in a SAMA combination.
As much oxygen as possible.
Empiric antibiotics. I'm gonna get there. You should probably stop ruining on my parade. Empiric antibiotics, especially if they increase the cough and the sputum, and you think the most common overall, and I might even have this as a slide, so I might spoil it, but the most common trigger of this is an infection, whether viral or bacterial. So you kind of treat them empirically. Azithromycin, doxy, augmentin are all pretty decent choices. Azithromycin is a kind of a pimping question. It actually has some anti-inflammatory benefit and has been shown to actually be good, like in the chronic setting as well. Steroids, methylprednisolone or solumedrol and prednisone, IV and oral. Common pimping question, is there any difference between those two?
Yes. Methylpred is strong.
No, they're exactly the same in terms of potency. IV and PO steroids, it does not matter. They're have the same bioavailability and everything's the same.
The dosing is different though.
The dosing is different, yeah. So like I think solumedrol is like 125, and then everything's based on like prednisone equivalents. So you can do that pretty. It calculates it for you for the most part. Then oxygen support, like you mentioned, it's very important. So what's our goal oxygen saturation in COPD patients?
About 88 to 92.
Great, and why? I gave it away the whole answer. So this is very high yield. This is a extremely high yield situation. So you'll have somebody come to the ER, telltale AUO COPD. They'll tell you that. And then they'll say that they were put on 4 liters of oxygen or whatever. Their current oxygen stat is 99%, and they start getting confused. Like acute altered mental status. You're like, oh man, what's going on? Do they have a stroke? Are they septic? Are they super hypotensive? Is their glucose okay? It's actually this really cool physiologic mechanism, really cool. I'm pretty nerdy. If you give them too much oxygen, these people are chronic CO2 retainers because that's the nature of obstructive disease. You retain CO2. So these people are so used to having hypercarbia or high levels of CO2 that does not drive their respiration anymore. For you or me, when we do exercise, we get hypercarbic because we get a little bit acidotic. That triggers us to start hyperventilating. Our oxygen is fine because we're healthy people, so we have good lungs. Decreased respiratory drive now because you basically take away the hypoxia that was driving all of this, if that makes sense. So they don't respond to CO2 changes. They only respond to oxygen changes. And now you like spoiled them, quote unquote, spoiled them with oxygen. So their body is like, oh, I don't need to breathe anymore because I have all the oxygen I could ever want. Problem with that is then they don't ventilate and then they build up the CO2. So then you get what's called CO2 narcosis. So you get the deteriorating mental status in that case. So your solution to that would be to just decrease the oxygen. If you need to, go to something like BiPAP so you can blow off all that CO2. Most common preceding event, I spoiled this one for you guys. Infection. And like we mentioned before, H flu is highly implemented with this, but could be a virus, could be any bacteria. What treatments decrease mortality? What another high yield step 2 question. So 2 things decrease mortality.
One's free.
What'd you say?
Oxygen.
Long-term oxygen, and one's a freebie answer. Smoking cessation, absolutely. There are some criteria that are actually pretty high yield for long-term oxygen therapy. So oxygen less than 55, SATs less than 88 at rest, or your numbers can be a little bit better than that, but they have signs of pulmonary hypertension or core pulmonale. Secondary polycythemia is actually a very common way that people will or on exams will test this. So you'll have initial lab values and their hemoglobin will be like 19. And it's because they're so hypoxic for so long that they've compensated by making more EPO and more red blood cells. So you can justify this person would benefit by oxygen because their body is saying that they need more oxygen in terms of that. So that's a good way to think about it. 25-year-old, chest tightness, shortness of breath, known history of asthma, they'll usually give you this, with multiple exacerbations. Recently, he's been sick with a URI and he's been out of his rescue inhaler. On exam, he's tachypnic and he looks fatigued. What's his best next step to evaluate his respiratory status? He's acute. Don't want to take him to clinic.
ABG.
ABG. Gold standard for assessing respiratory status. It gives you the true O2 sat, gives you the partial pressures, gives you are they acidotic or are they not. So here's his ABG for you. I didn't put reference values in there. I'll tell you obviously he's like a tad acidotic, just a little bit. PaO2 is a little bit low. PCO2 is normal, and bicarb is just like on the lower end of normal. What do you think about that? Is he super acute? Is he not acute?
His respiratory rate is 30.
Yeah, I told you that he appears tachypnic.
Yeah, I'm worried about his CO2 being normal.
Why is that, Gwen?
It
She's
should
worried
be-
about the CO2 being normal.
It should be decreased because he should be hyperventilating.
Incredible. So what's your best next step in management of this patient? Go a step further. You're going to intubate him. So this guy's PaCO2 is within normal limits inappropriately. So one of the few times we're going to see a normal lab value and shudder a little bit is in respiratory failure. So in someone like this, he's hyperventilating, respiratory rate, like you said, they'll usually give it to you somewhere in like the 30 range. He should be blowing off tons of CO2 at that rate. Like if you or I sat there for minutes and breathed at 30 respirations a minute, you would be you could blow off CO2 very quickly. This signals imminent respiratory failure and fatigue. So this means like the muscles of respiration are just giving out. And so he's breathing, but it's so shallow that he's not actually exchanging gas. So at this point, his CO2 should be lower and probably was lower earlier in his exacerbation, but now we're later on and it's starting to build up on him. This is an indication for intubation, for acute respiratory failure. Otherwise, how would we manage asthma exacerbations? So that's a very high yield point. I would know that. What do we think?
Inhaler that he's out of.
It's a great idea. So duoneb's very similar. PO/IV steroids. A lot of times it depends on like how's the patient doing. Like, can they take a medication by mouth, or are they too huffing and puffing to even do that? Or are they intubated, obviously? Oxygen as they need. Maybe. Not on exams, not high yield. Mag sulfate. Mag sulfate is considered a smooth muscle relaxing agent. So you can relax some of the airways with that, mostly in refractory cases. In most cases of garden variety asthma exacerbations, duonebs and a little bit of steroid will pull them right out of it. But good to know.
And then just for like clinical interview, if you ever are like staffing a patient with asthma, you always want to ask, have they ever been intubated? Have they ever been hospitalized for asthma? Because those are associated with mortality in asthma and likelihood of intubation. So those are risk factors for that. And then in the outpatient world, always ask when the last time you need prednisone. How many times do you need prednisone? Because that's a measure of severity and control. And then always ask how often they use their rescue inhaler. in the ambulatory setting because that's another measure of control.
Yeah, very good. And that all goes into there's a lot of different ways that people stage asthma severity, and that determines what kind of treatment they should be on. And we'll kind of go into that a little bit, but it's really this is a very specialized area. Like people, pulmonologists are pulmonologists because they manage asthma. They get good at it. And not that like primary care cannot do it. In fact, they should do it. But it does get into the weeds in terms of what criteria you want to use. So this is the asthma treatment ladder. This is just an aside. We're not going to quiz you. I kind of gone into it because I'm a little bit of a nerd, so we'll go into it. This is influx. So there's a new guideline set of GINA in 2023. So basically, like I don't know what this all stands for, but it's something about asthma. 2023, and then another asthma in 2020. The 2020 is the thing that's going to be seen on most question banks. However, I have seen some questions from question banks because they're kept modern that have taken into account basically one huge change in GINA 2023. So they're based on steps. So this is maybe like Tate's easy version of the asthma ladder. First line, in most cases, this is according to the 2020, is the PRN short acting beta agonist, which is albuterol. If you're only on a SABA and it's not cutting it, which they'll give you something, and there's actually some criteria to determine if it's not cutting it, but they'll give it to you in the question, like it's not doing enough, whether they go to the hospital or they're using it too much or whatever. That's when you add a daily inhaled corticosteroid. If you're still having trouble, you can add a long-acting beta agonist, but never, ever do we add only a long-acting beta agonist alone. Why? Kind of a pimping question. So LABA monotherapy is associated with increased mortality. So you would never use LABA monotherapy alone in asthma.
You're basically just masking symptoms with LABA monotherapy.
So I think that's kind of where it comes from. If you're needing more help, you can add a LAMA, or you start getting into the weeds. So this is like the biologics, like the anti-IgE antibodies. This is like chromalin or
Usually like your respiratory biologic like Dulera, Xolair,
and this is when you would refer to a pulmonologist, someone who
Fasenra,
specializes in this, because this is going to require a long insurance process to get biologics
Dupixent.
covered. Yeah, I've seen Dupixent most, honestly.
Usually
Um,
Dulera
Yeah, but
or
some people
Fasenra's
end up
IL-5.
on. This is sometimes a setup for test questions. People on daily steroids, if they're refractory, they might be on like prednisone every single day. The big addition from GINA 2023 is that you can use budesonide formoterol as a first-line PRN agent. So I actually did get tested on this, but it was an interesting way that it happened. So I won't go into it. But it's a LABA ICS combination that now can be used first line.
This is Symbicort.
Yeah.
So you just use Symbicort as your PRN. So instead of albuterol, you just prescribe Symbicort, 2 puffs twice daily, plus 2 puffs for exacerbation.
So yeah, kind of a new thing. It used to always be the SABA first line, but now you could start with this and it would be totally guideline, like supported by evidence. An extra point, exercise-induced asthma, you can use the SABA or the ICS LABA 10 to 15 minutes before exercise. That's actually pretty commonly tested because it's a pretty simple, like easy fix. Like, oh, I have asthma, but it's only when I run. It's like, okay, 10 to 15 minutes before you run, take a puff of your inhaler and off you go, and usually it does pretty well. Okay, what does that say up there? Restrictive lung disease, probably? How do we characterize restrictive lung disease in general? Sure.
Don't have an FEV under 70.
Good. So you have a greater than 70, or normal FEV1 over FEC ratio. So greater than 70%. Examples of restrictive lung disease, just spit them out. ILD, great one, probably high yield. You have extrinsic factors. This is like the classically tested ankylosing spondylitis patient that's so kyphotic that they can't move their chest wall. Pneumoconioses, so silicosis, asbestosis, all that stuff. Sarcoid, obviously, always pops up on everything. And then idiopathic pulmonary fibrosis, which is kind of like the main like interstitial lung disease. And then hypersensitivity pneumonitis is actually restrictive pathology. Drug toxicity, which there is a slide about later. Anybody know the drugs that cause pulmonary fibrosis just off the top of their head? Not digoxin, but close. We'll go into it later, but just keep that in mind because they are pretty high yield. Because lung fibrosis is no joke. For the most part, there is actually a lot of research happening on idiopathic pulmonary fibrosis, and I believe there are some treatments that are kind of actually working. But for the longest time, idiopathic pulmonary fibrosis, there wasn't really much we were doing for folks. So now we are. I think there are some. I'd have to research it a little bit more.
There's one big one they still like to test. It's what is it? It's a something inhibitor. It's like whatever. It's bosentan.
Oh, bosentan. Yeah, it's an
Yeah.
endothelin receptor antagonist. Is bosentan.
Whatever.
Physiology, restricted lung expansion. So obviously that makes sense. If you can't expand your lungs, you don't really get good full breaths. Okay. Shortness of breath in the following. Well, that's rough.
Don't read the text.
Don't read the text. Okay, what's he got? He's got a little bit of fullness
Hey,
here,
well,
I'd
don't
say.
direct them to it.
Hilar infiltrates or hilar fullness. On the exam, very much be worried about like demographics here. Classically, this is an African American female, middle aged.
They stopped
presents
giving
like
that.
this?
They stopped giving that though.
Yes, I would still be aware of it just because like every once in a while you'll get the dead ringer and then that'll tell you it's sarcoidosis and then they'll ask you something about sarcoidosis. Like it won't be diagnosing it, it'll be what okay. Obviously, we gave you it's sarcoidosis because we gave you the demographics and a dry cough and hilar fullness. I didn't think of this nickname, but someone did.
Have you heard of that?
I never
You
have.
heard of that?
No.
Yeah.
Go.
I
go
think I
off,
made
Mike.
this slide. I made this so sarcoids are often called the great mimicker, both in derm and in medicine, but it can basically affect every organ system. We can go head to toe. So we can start you can get brain sarcoid, you can get ocular sarcoid. What does it cause in the eye? Uveitis. What about in the like facial nerves? You can get Bell's palsy from sarcoid. What about in the heart? You can get restrictive cardiomyopathy, and what else? What other conduction issue? Yeah, you can get AV block from sarcoid. And the liver, you can get sarcoid infiltration. On the skin, you can get sarcoid. So it basically can affect every organ system. So it's kind of nicknamed in medicine as the great mimicker. You'll hear it at some point. There'll be a patient and they'll be worried about sarcoid. When when a lot of different organ systems are affected and they're like nodular, you can think of sarcoid versus like, obviously metastasis, things like that.
Very nice. So what did you find on path? If you took a sample of one of them lymph nodes in there.
It's
That's amyloid.
2 words.
Eggshell.
Isn't that silicosis?
Yes, never mind. What am I thinking? Is this something like non-casing?
Very nice. Non-caseating granulomas. What if you had a caseating granuloma in there? TB, very good.
Or what other type of infection? Type. Kingdom of speed. Fungal? Is that what you said? Yeah, fungal. Fungal or TB.
Very good. Here, now this is where it starts getting really high yield. So they have sarcoid. What's their possible lab finding?
This is where it starts getting high yield.
Yeah, this is just a given. Almost every sarcoid patient on exam will have calcemia. This one is a little bit more nuanced. An elevated plasma ACE level is actually kind of decent. I don't know what the sensitivity specificity is, but if you ever see it, they're talking about sarcoid.
In cutaneous, there's a Dr. Shields published this, but in cutaneous sarcoid, ACE levels are not very good test.
Well, good thing we're studying the medicine shelf. We're worried about pulmonary disease.
I actually don't think the elevated ACE level is that good.
No, it's not, but it's tested. That's why it's on there.
Yeah.
Not because it's good, it's because
why
it's
is there hypercalcemia?
Oh yeah. Why? What's the reasoning behind the hypercalcemia? And I have it there. You can see it.
No, you don't.
Yeah, I do.
No, you kind of do. That's like a half answer. If I was an attend, not that I would ever do this, but I was an attending pimping a med
Is
student.
this what has to do with the vitamin D?
Yeah.
Yeah.
Yeah. So 1-alpha hydroxylase is an enzyme that activates 25 vitamin D to 125 vitamin D, normally found in what organ? Where in the kidney? Where in the kidney? Yeah. This is tested. This is high yield. Proximal convoluted tubule. Now, why would there be elevated 1-alpha hydroxylase in sarcoid? Yeah. What cells in the granulomas express 1-alpha hydroxylase? Yeah, epithelioid macrophages in granulomas. Notably, in clinical practice, basically any granulomatous process, including like lymphoma, sarcoid, histoplasma, they can all cause hypercalcemia. But on exams, especially like step and things like that, it's pretty limited to sarcoid.
Yeah, I would agree. And just knowing that 1-alpha hydroxylase is the reason behind that. Treatment for sarcoidosis.
If it goes away spontaneously.
What if they're not symptomatic?
Wash.
What if they are symptomatic? This
A
is
dermatologist's favorite word?
RVUs.
Steroids. RVUs. It's insane. So steroids. If they're symptomatic, do steroids. Okay, that was funny. 60-year-old
Oh, we
woman.
got birds.
Yeah, we got birds in there. She has dyspnea,
Tell which ones I wrote.
dyspnea, leg swelling, and fever. He owns pigeons. There he is, right? Oh no,
Woman.
the 60-year-old woman. Never mind. Hypersensitivity pneumonitis, secondary to the birds. To the birds. Now, what would you see on path? Once again, not my slide. So I mean,
Yeah, I mean, yeah. Actually, the big thing with note with this slide, first of all, what imaging do you want to get for hypersensitive pneumonitis? It's very specific imaging.
oh yeah. Same with interstitial lung disease.
Yeah, any ILD, you'll want this type of imaging.
High-resolution.
High res CT.
High res CT, very good.
Very good. And then these patients often present with fever. Fever is actually pretty sensitive for hypersensitive pneumonitis, which I did not know. But I had a patient with hypersensitive pneumonitis.
So what's the path finding, Mike?
I'm pretty sure it's granulomatous.
Non-case.
I wrote this, so
you did. So I hoped you'd get it right because I didn't know. Treatment for hypersensitivity pneumonitis.
Yeah, what's the cheaper one? I guess.
Get rid of the birds.
Yeah.
Avoid the offending trigger and steroids.
What is that?
What is this?
I see it. I know what it is because I put the
Can you put
slide in.
picture on?
Any budding radiologists?
PE.
Yeah.
Yeah.
Bingo. As you can kind of see, we have the pulmonary arteries there, and we have complete blockage of those. That's no bueno. So this patient presents to the ED and they're hemodynamically unstable. Well, I
This is a weird answer.
oh, is it?
Not weird.
Oh,
but
no, yeah, I know what it is. I know what it is. So hemodynamically unstable, 80s over 60s, tachycardic, looks like garbage. What do you do?
you're the intern. You're the med student.
Go get my attending.
That's right.
Go and get your attending, get your senior
That's
on the
what
phone,
we'll get
page them,
someone else.
get them there, and then they'll page someone else. Okay, so that's one option is IR, thrombectomy. That's one option. Either way, the clot's got to come out, right? Clot's got to. Clot's got to. Yeah. So what's the other answer? On exams, this will most likely be the answer because you're supposed to play the role of an attending. You're an attending. That's exactly right. So you'll call the PE response team.
That's
then
the right answer.
Thrombolytics. You could give somebody TPA in this instance. You could also, if you have somebody capable in IR that does thrombectomies, you can go at it that way, especially if there's somebody with a contraindication to thrombolytics, like recent intracranial bleed, stuff like that.
Is it intracranial bleed ever or recent?
I think it's recent, 6 months maybe. I don't know.
I think
I'd
it's
have to look it
recent
up.
GI bleed
Ooh,
and
you might be right.
intracranial bleed
Ever.
ever.
I think you might be right. We'll have to look that one up, Strudel fans. How to diagnose?
Oh, no.
This is very high yield. How to diagnose a pulmonary embolism when pregnant?
You still have to get PE.
Not necessarily.
It is VQ. because
VQ scan,
I know
but tell me
because-
this. Tell me this really
Oh.
quick. What if the VQ scan is negative?
Then like, what's my next? Like, yeah, treat anyway.
So you have a pregnant lady. She's, maybe not completely totally unstable, but she has a PE and you're pretty darn sure. You get a VQ scan because you're being conscientious about the CT radiation exposure,
Don't
but
worry,
it's negative.
Get a D-dimer.
Never get a D-dimer. How to diagnose it? VQ scan. If it comes back negative, you're getting the CT.
Okay.
And the reason for that is because this is a high mortality position to be in. Being pregnant already puts you at hypercoagulable risk. That's likely a big clot. They're unstable. You need to know if there's a clot there or not before you throw TPA at someone with a placenta that could very readily bleed and be very dangerous for both mom and baby. So it's very important that you get the diagnosis correct here. So you could do the CT angio in that circumstance and just eat the radiation exposure. That's a great question. Probably depends on institution.
I've seen actually. There was a contrast shortage maybe like 3 or 4 years ago. So yeah, some hospital systems were because this was back when there was a huge supply chain before
COVID.
but now it's inflation. But anyways, there was no contrast available for CTs, including Either way, there were a bunch of VQ scans done during that time.
Very good. So how do we treat it? How do we treat a PE?
Oh, it
Oh,
takes
what'd
like
you say?
it takes like
Oh, how? Yeah.
it doesn't take that long. Like
I don't
it's
think
not as
so
fast
either.
as CT, but like
I'm just
20
saying, if
minutes.
they're hemodynamically unstable, you just get CT.
Yeah.
Yeah,
Yeah.
probably. I don't know. In real life, on exams, think VQ.
Is
then
that what
CT.
is that what you're getting at if they're unstable?
Yeah. That would be a tough situation to be in. That would take a little bit of clinical gestalt, whether you want to go after the TPA right away or
Everybody
thrombectomy or
needs-
whatever. How to treat if this person is actually stable? So stable DVT.
P-
Maybe.
P-
So yeah, stable PE. How do you treat it? Okay, you can use heparin if you wanted to. What do you? Lovenox you could use, especially if you're admitting heparin or Lovenox. Or a DOAC. And DOAC, now, back in the day,
When you used to practice?
when I used to practice, we used to have to bridge everyone to warfarin. We you used to have to give a heparin derivative, whether unfractionated or I don't even think Lovenox was maybe around then. You'd have to heparin bridge into warfarin, and then that would be their long-term anticoagulation. So they'd have to be admitted during that practice. Nowadays, if a PE is diagnosed, is small enough on CT angio, and is pretty stable, you can send those folks home on a DOAC for 3 months, 3 to 6 months, depending on the risk and stuff like that, and get away with that. And that's evidence based, and that's good medicine. That's good service.
I have a really high yield fact actually when you're
Go ahead.
dictating. So this is very high yield for medicine in general. So any medication that's been around a while, so clinicians used to just add eyes to anything. So they would say, we're gonna heparinize them, or we're gonna give them digoxin, so we're gonna digitize them. So you could say that basically for any medication when you're presenting, and say that we'll, warfarinize them, heparinize them, digitize them. It's phenomenal. That's very high yield.
That just means like anticoagulant.
That means
Okay.
Well, it's
It means you're-
specific. It's specific to the drug. Like digitize, like we're gonna give them dig.
yeah, exactly.
Actually, amoxicillinized something.
Yeah,
Sure.
absolutely.
We're gonna have.
So
Absolutely.
how to treat if stable?
when you-
Depending if they need, it really depends on whether or not they need inpatient, and that's dependent on a lot of things. Like if they need a little bit of oxygen via the nasal cannula, you're not going to send them home. So you'll admit them, and you'll usually do like a little bit of Lovenox overnight.
You'll heparinize them.
You'll heparinize them, and then you'll transition to a DOAC with monitoring. You will not have to bridge, but there was a time when you had to heparin bridge into warfarin. Why do you have to bridge into warfarin? What happens if you give warfarin straight up? Sure,
You're
that's
How
one of the
does
reasons.
warfarin
uncoagulable
work?
at that time because
You-
of your protein S and C deficiency.
Okay, so you are hypercoagulable for a period of time because of protein S and C deficiency. So how does that present?
With skin necrosis.
With warfarin-induced skin necrosis. That is very well.
Is that only if you're like have protein C deficiency?
Nope.
based on-
It's worse if you have acquired protein C deficiency for whatever reason, or hereditary deficiencies. It would be worse or higher risk. But even in general, anybody started on warfarin, if you did not heparinize them first, to bridge you into therapeutic warfarin INR ranges, which is what? Therapeutic INR?
Depends on
That's
the
right, is that
indication.
what-
It does. If it's for a valve, it's 2.5 to 3.5, and if it's just like normal like DVT, it's 2 to 3.
Usually it's for AFib.
Yeah,
If they're gonna be on
I'm
long term.
gonna consult on.
That'd be a good idea.
Yeah.
Okay.
Warfarin dosing for pharmacy.
What do we got
Next.
here?
Next.
Oh yeah, here we go. What's that person got?
And they do have a
They do have a necklace. The necklace sign. It's very high yield.
There's no arrow sign.
Is that not a-
There is
On
a
my
shift.
20, It looks like a pneumo.
What is pneumo? Pneumonia?
Pneumothorax.
Great job.
Sorry.
Really good. No, I'm kidding. I'm just
So specifically tension.
it's
And
gonna
why,
be that time of night.
is it a tension pneumothorax? You really don't know until you start looking at vitals. So this could just be a pneumothorax,
Well,
but you
no,
do
there's
have
midline shift.
there is midline shift, but I think you could say without tension physiology if you did not have hemodynamic change. But in
Fine,
general, if
they're
there's
unstable.
midline shift, like that person, their trachea is deviated contralaterally from the side of the pneumothorax, then you can, I would be willing to call it a tension pneumothorax. I'll let Mike have this one. So we'll say it's tension
I
pneumothorax.
called it.
Next step in a tension pneumothorax, let's say they are unstable. They're becoming hypotensive, they're tachypnic, they're tachycardic.
Yeah, pull that air out.
Yep. So you're going to stick a needle in them. Do a needle thoracostomy. Is that definitive treatment for a pneumothorax?
Oh, wait, check this out. What if you don't have a chest tube available?
You can use a pen.
Oh,
What
whoa.
would you use?
You watch a lot of MacGyver. You can do what? Has anyone heard of the 3-sided bandage?
A three-sided occlusive, partially occlusive dressing.
Yeah, 3-sided partial inclusive. Yeah, chest seal. So do they don't know the logic behind that?
Yeah, flat air, it's a one-way flap.
Yeah, one-way flap. So air can get out, it can't get back in. But usually, no.
Chest tube
Chest
placement is
tube. I
definitive
made these
management.
slides.
No, you did. You made some of these.
Yeah, I made this one.
You made some of them. You made some of them.
I walked in.
So chest tube placement is still definitive management, especially in somebody where this is starting to become recurrent. But stabilizing
Blacklist one time. Sorry.
stabilizing management, usually done by EMS personnel, is going to be a needle thoracostomy. But in the ED, if they actually have a true pneumothorax and they need management by a physician, a lot of times the chest tube will be the preferred form of management.
Yeah, you can just say that we should throw in a pigtail. That's the typical chest tube used.
I don't think step 2 uses that. The VQ mismatch, this is high yield physiology. We're not going to spend the time on it because it's late. But a lot of times the correct answer to a question when they ask about why they are hypoxic will be because there's a VQ mismatch, and that'll be one of the options, and that's a good choice to be had. Remember, this is like the whole concept of like dead space versus what's the other one? Dead space and
perfusion?
shunting.
Yeah,
Yeah,
versus
dead space
shunting.
versus shunting and what pathologies cause what. It's high yield to know that, and I would have a good understanding of it because it helps you classify pathologies and why you see what you see. But a lot of times they'll ask, what's the pathophysiology behind this patient's hypoxia? And it's a VQ mismatch. And they'll either tell you shunting or like increased dead space. So that can be answer options as well. So just have that in the back of your mind.
Right ones?
Yes.
Okay.
Yep. Or this is a poorly ventilated.
So
this
when
is
would
like-
you have a perfusion defect?
Yeah, what we call a perfusion defect?
Like the one on the left?
Yeah.
We talked about earlier.
This is a
P-
this is a
yeah,
ventilation.
PE. So PE classically causes a VQ mismatch, very high yield. On the one on the right, that'd be like pneumonia, poorly ventilated alveoli, or atelectasis. And then the blood, even if you have very good perfusion there, you will have basically blood that hasn't really been well oxygenated.
Very
All
good.
right, very good.
Very good. Yeah.
So pneumonia can present with shunting if there's a complete occlusion of the alveoli, but clinically it's probably more VQ mismatch. But on exams, it'll be shunting.
Very good. So
Uh,
what has this person got? Obviously that kind of gives it away, but what is this? Okay, so you have a nice meniscus sign there, pleural effusion. If it's small, sometimes they can be hard, but what's your pathognomonic finding that you would see down in here? Blunting of the costophrenic angles, very good. So even if small, you will see a loss of this sharpness here. Obviously, this is a big pleural effusion, so you have a big giant blunting of the costophrenic angle or a meniscus sign. All right, so transidative
guess who made this
effusions.
slide?
Yeah,
Let's
who
start
made
there.
this slide? Who would have thunk?
What's the over on tape making the slide?
The over? That's not really okay. So determining transidative pleural effusions. What do you use to analyze pleural effusions? Lights criteria. What is Lights criteria? Can somebody give me a few?
5, 6, 7. Point.
The ratio of protein is 0.5. Right?
Yes.
Ratio
Yeah.
of
The LDH.
LDH is 0.6. And the
7.
and it's
It's like 2/3.
if it's
Yeah,
2/3 the upper
Yeah.
something
Something like that.
Yeah. So pleural fluid protein greater than 0.5, LDH 0.6, and then the fluid LDH, or I think it's supposed to be protein. Or what is that supposed to be?
No,
It is
it's
LDH.
LDH.
Okay, yeah, it's the second LDH. Okay. Causes of transudative pleural effusions.
Oh, thanks, sorry. That's my clear one.
Heart failure?
Heart failure.
What's the other big one?
Liver disease.
Yeah.
Yeah, so fluid overload states.
There's one more with the kidney.
Hepatorenal.
No, losing protein. Nephrotic syndrome.
Nephrotic syndrome. Very good. Okay, so then there's exudative.
Awesome.
Obviously are going to be, so the way to think about it is you're going to have more protein and more LDH in the pleural fluid because the respiratory membranes or like the capillary membranes have been made more leaky by some cause of inflammation, whether rheumatic or malignant or infectious. They will have exudative effusions.
I
So-
will say I've seen rheumatic fever
Rheumatoid
or
arthritis.
rheumatoid arthritis. Yeah, not rheumatic fever. Rheumatoid arthritis. So that's like you'll get elevated protein. So it'll be exudative, but then there'll be no cell, like no really cells.
But there'll still be low glucose.
There'll be low glucose, but no like infection. All the cultures will be negative. That'll be rheumatoid arthritis.
How about a TB effusion? What would be elevated in a TB effusion classically?
I don't know.
I might have to look this up.
Isn't it?
Let me look it up.
The brain is saying red snappers.
Red snappers?
Yeah,
Is that a fish?
that's the TB macrophage pathology.
Dude, that's epic.
I'm pretty sure it's adenosine deaminase or ADA. You'll have
Yeah, I've seen that.
You'll see an elevated ADA level within an infusion, and if you see that, in the words of one of my heroes, Divine Intervention, stop reading the question. It's TB. Okay.
You gotta find a hero. Yeah, I was gonna put the mewing one up.
Oh, okay. Yeah. So he's not mewing. He is currently sleeping. How do we define obstructive sleep apnea? I don't even know where Mike is going with this. Okay. Okay. Yeah, that's nice.
Stop that.
Oh, there you go. I've never even seen that before. Very nice.
That's not big.
No, I've never seen it. Never seen it.
It's actually like required, I think, by like Medicare that you document the stuffing prior
Huh.
to cirrhosis.
Well, you learn something new every day. That's why we're doing this. How do we confirm a diagnosis of OSA? What do you send your patients to do?
What's the big word? They can pimp your meds.
Polysomnography. That's why. That's
everything you learn.
Sounds smarter.
Everything you learn
Don't say
in med school.
Polysomnographize them.
The whole point is to be able to pimp your meds later on. It's a privilege of doing medicine.
yeah, it is. It really is. We're very lucky. Type of sleep apnea. The different types
Obstructive.
versus central. So what's the difference of obstructive versus central? What causes obstructive sleep apnea generally?
Large habitus. Obstruction.
Okay, large habitus. Classically, the most common actual like risk factor like measurement wise is a thick neck. So like neck circumference,
So I think it's 17 inches.
yeah, something like that. Yep, high Mallampati for your anesthesiologist out there. Kind of makes an anesthesiologist wince a little bit when the Mallampati's too high. Central sleep apnea. What can cause central sleep apnea? Okay.
Something about the,
Respiratory drive.
yeah.
So what kinds of things?
Baroreceptor reflexes.
Yes,
kind-
baroreflector reflex. Three big that causes central sleep apnea.
Go ahead. So one of them you already said, baroreceptor. What kind of like? What about medications?
Opioids.
Okay.
What about a hypoventilation syndrome? Obesity, hypoventilation syndrome. What's the third one? Oh, what about really critically ill patients, like with heart failure? This one is a very specific name. Do you know this one, Tate?
I don't. I might when you say it.
Giant strokes.
Oh, Cheyenne Stokes breathing.
Yeah.
Sure.
Yep.
Nice. Okay, yeah, there we go. Associated with what arrhythmia?
Oh, sleep
Obstructive
apnea.
sleep apnea.
Yeah. What arrhythmia is very
Becoming
common.
very high yield because there's a big push to diagnose sleep apnea because it's causing a lot of like comorbid conditions. So atrial fibrillation, yeah. People can get thrown into AFib just because of one of these hypoxic episodes where they basically suffocate. Holiday heart is more from alcohol. Yeah, and then this one is from like being hypoxic acutely.
Holiday heart is when you get AFib from drinking alcohol
And they call it holiday just because you drink.
because
drink
they're
on the
drinking on the holidays.
Okay.
Yeah, they're holiday warriors.
You're
Very good.
testing.
Treatment for obstructive sleep apnea. What about if you had to tell the patient something on an exam? They're wanting you to be very, very mindful.
Lose weight.
Lose weight is great. Weight loss and CPAP are your big ones.
Oh,
So
that's pretty epic.
lose weight. So
I actually
anything
made these yesterday. I forgot what I put.
that's pretty epic, he says. Okay. Yeah.
Did you say so?
Weight loss and CPAP
I love
obviously the
complimenting
intern,
myself.
Especially on screen.
especially on stream, it amplifies the compliment because you get to watch it back. Oh, we have a little bit of cheating there. Okay. Oh, this is a classic question. This is a classic question though. And I like this question a lot. It's been tested a lot for me. So accident at sea, found by members of his family unconscious in the water. He was resuscitated in the field, and he's been vitally stable in the ER. Getting some further workup on day 2 hospitalization, the patient begins to have increased oxygen demand, tachypnea, tachycardia. On exam, there are diffuse crackles everywhere. He's starting to become cyanotic, and he gets a chest X-ray of his chest, obviously, and it's shown there. So what's happening to this guy? This is 2 days after a traumatic experience involving the lungs.
ARDS.
Very good. So what's the criteria for ARDS?
Dude, I remember these. It's like within like 1 or 2 weeks of incident or implicated event, no other likely diagnosis, and then it's like PaO2. There's like a PaO2 divided by PaO2 divided by inspired O2 ratio, FiO2 ratio. I don't know, less than like what, 300 or something?
Very good. So is the criteria going to be tested? Not necessarily. What is the big thing to know about ARDS? How would you say it? So it's a cause of pulmonary edema, but what precedes it?
I got
ARDS is what? At its core.
It's like
It's non
Non-cardiogenic.
non-cardiogenic pulmonary edema. So that means as part of the criteria, you can't explain it with any heart problem. So you did the EKG and the troponin, you've done the echo, everything looks fine. And within 1 week of the insult, this is also very high yield because a lot of times this question will give you that everything looks fine. So this guy had a near drowning experience. He's been fine for a couple days, receiving workup for why he fainted in the water. And now on day 2, it could be even day 3, could be even a week after, he has this acute respiratory distress syndrome. Bilateral findings, though, it's obviously that also makes it more likely. Whiteout lung is also kind of what you're looking for. You can see it's every lobe, it's everywhere. So causes, they're pretty innumerable. There's a lot of things, any pulmonary insult. So drowning, and this is kind of a high yield fact. I've kind of been tested on it. Surfactant washout.
I've been tested on it.
Yeah. So you inhale all the water like washes out your surfactant. You basically just have like rapid onset,
I mean, what happens in children?
NRDS.
Yeah. So
Their
with
surfactant-
NRDS is due to reduced surfactant production, so that like with drowning, it's a similar presentation. All right, ARDS, yeah.
Yep. So
Everything that
drowning,
makes you sick.
infection or sepsis, that's great. Aspiration, pancreatitis is very high yield. That's one of the things that pancreatitis can cause a complication. Any type of shock, like you can have somebody go through hypovolemic shock, then they recover, then boom, something happens to their lungs. That can be ARDS. Any trauma like pulmonary contusion can lead to this. Certain drugs can cause it. So obviously treatment, I kind of gave it away at the beginning. The big main principle of treatment here is PEEP. Problem with PEEP is if you have too much PEEP, you can get barotrauma. So you could cause a pneumothorax just by putting too much pressure in the lungs.
Yeah, normally on the vent settings, you want to keep like the total pressure a little bit lower. Like you need PEEP, but you don't want the peak pressure to be lower because you don't want to cause more damage to the alveoli.
Very nice.
All right, very good. That's just another
Another
ARDS.
ARDS. So yeah, obviously it's a very threatening pulmonary X-ray. You're like, oh gracious, like it was terrible. Okay, cystic fibrosis is incredibly high yield in every test because it kind of is a multi-system disease. So obviously in pediatrics you're going to see it. You'll see it in GI type stuff, so it pops up on internal medicine for that, and then also of course the pulmonary findings. So what's kind of like the whole syndrome of cystic fibrosis? So obviously recurrent lung infections, we'll give you that one. That's the obvious one. What are the other things you'll see a patient present with? Statorrhea, or pancreatic insufficiency. Great. Yep, they can basically develop diabetes at a younger age.
Electrical disability.
I think there is a little bit of a tie to intellectual disability. I'm not sure if it's
Not
involved.
really.
Maybe not. Okay. The other thing I've seen is salt wasting, hyponatremia.
And then what
'cause they-
about a
they're like-
ET exam?
Oh yeah, I have a little point on this. This is very high yield. Nasal polyps is very high yield as well. So you have this patient, chronic respiratory disease person, all those things, malabsorption, diabetes, sweat dehydration, infertility due to absence of the VOS, extremely high yield. I never would have expected it to be in that high yield. But yeah. They'll say like, why is this person infertile? And there will be a lot of things that like go after like an endocrine cause but it's really because of congenital absence of the VOS. And then recurrent pulmonary infections obviously.
Oh,
And there you go. Mike stole it from me. Nasal polyps, very high yield. What about other causes of nasal polyps? Okay, chronic allergic rhinitis can have nasal polyposis. There's one other
Aspirin.
incredible. So AERD, AERD or aspirin exacerbated respiratory disease. So yeah, this is basically like a hypersensitivity specifically to aspirin. And I didn't put it in points, but yes, that is one of them. Is the aspirin-induced one, and then CF, and then chronic rhinosinusitis as well. So now you have known CF, so you know about him. He has pneumonia again. It's like many times. What's the most likely bug in a young person like this?
Or is it the?
Is it Pseudomonas?
I don't know. It's like
It is
Pseudomonas
staph.
for a
Say it with
certain
your chest.
age.
Say it with your chest. Come on.
I don't know. Is it? I'll say it with my chest if you give me a nod that it is.
It's Staph aureus. So this becomes very high yield, and it's so Staph aureus in like an 18-year-old, and it's pretty.
is that the switch now? Is that where the
I don't know where the line is. It's just said like younger and older, and it
Yeah.
depends because
I
the
know
life.
yeah.
It's tough because CF used to have a lifespan that was super low. So by the time there was not really much we were doing. Like it was like treatment was not that successful. Now we have people with CF living into their 50s and 60s with relatively decent lung function. So you do have like older patients with CF. Now, I haven't personally taken care of one, but it's crazy that they live that long now. 30-year-old with known CF, and now they have the pneumonia. It's the exact same presentation, but now he's a little bit older.
Pseudomonas.
So now it's Pseudomonas, and this is the classic one associated with it.
Okay.
And
good stuff.
the important thing is that like these are both colonizers at this point. So you would say that they're colonizers, so therefore should be treated, even if there could be a cystic fibrosis patient that gets pneumonia, and it could be perfectly fine community acquired pneumonia, just like everybody else. But they are considered chronically colonized by Pseudomonas, so they're getting treatment for Pseudomonas either way. Okay, this is kind of getting towards the end of the pulmonary section. So then we'll
we're
probably
calling it a
we're calling it a pulmonary. And Tate's gonna independently record the renal section.
Sure.
Drugs with pulmonary effects. So fibrosis. Give me some examples. We already kind of mentioned one in passing.
Amiodarone.
Very good. Amiodarone.
Chemo drug. What's
I do think cisplatin does have some
Cisplatin
does have some pulmonary, but I don't think it's like blatantly pulmonary
There's
fibrosis.
one big one. It also causes liver toxicity. Starts with a B.
How about
No.
bleomycin? Bleomycin. So that's part of the ABVD type track for like Hodgkin's lymphoma and stuff like that. That treatment regimen. So bleo, one of the more common ones, especially recently, and it's actually a hypersensitivity pneumonitis that's been tested a lot more, is actually nitrofurantoin. So commonly given for cystitis.
Seen that.
I think you did actually have like a real life case of that. You told me that, I think, right? Or did you see it tested? Someone I
saw it
know has
tested.
seen this in real life. So methotrexate, also very high yield because people get that a lot. Nitro, like I said, carmustine, which is another, it's a more like used for intracranial malignancies, less common on exams. Bleomycin, very common. Busulfan, which is another chemo drug. You can have like the busulfan tan. Usually those folks are like hyperpigmented skin. And then amiodarone is probably the most commonly tested overall, I would say. So
yeah, amiodarone,
what are your-
methotrexate,
yeah.
nitrofurantoin, bleomycin.
what are your labs in amiodarone? What are the organs that you have to
think I
test
have that,
function
don't I?
for?
Don't I? Yeah.
Oh, there you go. I was just anticipating you. Okay. What do you test? What organs are you worried about with amiodarone? We already talked about the lungs. That's one.
PFTs. What does amiodarone have a lot of
Not the kidneys.
in it? The drug itself.
What's it made out of?
Why is there iode?
Okay. So what are we worried about with iodine? Okay. So you got lung, thyroid, and liver. We're gonna look at the liver as well.
Yeah,
So
they
we're
got
gonna do
put
LFTs.
right?
Hope you did. Yep. So LFTs, PFTs, and thyroid function. Yeah, I think there is something. Amiodarone is largely iodine by weight, so you're giving a lot of by molecular weight.
It has 3 iodine molecules.
Very nice. And iodine, pretty heavy molecule, if I remember from my chemistry
Yeah.
days.
That's right.
Been a long time.
Is that it? Oh, I have
No,
one.
a couple miscellaneous, so bear with us. Okay, 30-year-old female. Oh, this is actually very high yield.
Yeah, I've
She
seen
had a
this tested like so many
I don't know why it's tested so much. I don't know. So she had a septoplasty for like a deviated septum or whatever. She's noted to develop a post-operative hematoma, and then now she reports this whistling sound when she breathes. What happened? What else can cause a nasal septal perforation? Bingo. So snorting cocaine can get you there as well. And digital trauma as well. So incredible differential. Honestly, very high yield. Maybe just because it's kind of fun to ask about the whistling.
Septal piercing.
Yeah. So obviously, yeah. So it would be cocaine specifically because of the intranasal route, and then it causes vasoconstriction, and that tissue gets ischemic. Granulomatosis polyangiitis is also another cause, but that's usually in the setting of like chronic sinopulmonary disease, and then it's been going on for a while, like repeated insults. And then digital trauma is a very good differential as well to have. Okay, 40-year-old male, ED after an MVC, extensive bruising over the left chest wall. This is more of a surgery shelf, honestly, but it is very pulmonary. Associated rib fractures. He's admitted and postoperatively develops respiratory distress. Chest X-ray is done and it shows an irregular area of diffuse patchy infiltrate over the left lung that is not confined by any particular lobes. Bingo. So that's kind of key. It's not confined by a lobe. So it's not a lobar infiltrate. Even atelectasis is lobar in nature, right? It'll follow the borders. Pulmonary contusion is very irregular in nature. Typically, you'll get an X-ray. I don't know if my friend might put one in here, but they'll have rib fractures overlying it as well. Treatment for pulmonary contusion? Supportive care. Monitor because it can lead to ARDS. It's one of those things that leads to like that kind of sequela.
Very
Boom.
good.
Woo!
Alright, great.
Thank you for listening. Yeah, you guys stayed 35 minutes late, and we're done. Someone just was very wordy with cardiology review tonight. Cut, by the way.
Yeah.
Dude,